tales. So as we know, we are indeed very fortunate that we have Swamiji Atma Priyanandaji from the Ramakrishna Mission to grace our stage today. Just behind you, you see a poster for National Myeloma Congress. And aren't we all amazed at the rate at which science is progressing? We have had challenges, and these challenges continue to mount as the new generation steps in. We worry about work, we worry about work pressures. Medicine remains a challenging job, whatever generation you choose to pick and compare yourself with. If you go ahead with a clean heart, if you go ahead with a sense of compassion, if you feel that your fellow human being needs all the love and care that your little heart can give, sometimes it can put a lot of pressure onto your heart. And that's the time when we seek recourse not in tomes, not in books, not in journals. We seek recourse to the greater things in life. We understand the meaning of why we are here and what service means to you as a human being and to the rest of the world. So you may be that little spark that would be giving out light to so many other people. Yesterday we had Manjari. I see Dr. Arpita sitting there. It is a bond that we all need to build and nourish and nurture as we go along. So we are indeed fortunate that Swamiji, who is also a scientist, is going to put these into perspective today for us. And we are indeed fortunate to have him amidst us. But by way of an introduction, I would request Dr. Somendranath Rai to start the proceedings for the day today. And thank you all for joining today's tales.
Good morning. Mike, catch question. Hello. Hello. Good morning. Friends and colleagues, it is indeed our proud privilege to introduce Swami Atma Priyanandaji Maharaj, a revered monk of the Ramakrishna Vivekananda order, who embodies the perfect blend of spirituality and academia. A distinguished physicist with a PhD in theoretical physics, Swami Atma Priyananda has made significant contributions in the field of elementary particle theory. Inspired by the ideologies of Ramakrishna and Vivekananda, he has dedicated his life to spiritual liberation and service to humanity. As a senior administrator, he has played a pivotal role in shaping the Ramakrishna Mission Vivekananda University, serving as its first vice chancellor for over 15 years. Currently, he is the pro-chancellor of Ramakrishna Mission Vivekananda Educational and Research Institute and secretary of the University Center at Balloon-Mott. A global citizen, Swami Atma Priyananda is a member of numerous organizations promoting peace, harmony, and interfaith dialogue. He has worked tirelessly for the holistic welfare of children worldwide. Atmanang Moksha Jagadhitayo is a Sanskrit phrase. If we translate it, it will be for one's own liberation and for the welfare of the world. This phrase reflects the ideals of Ramakrishna Mission and the Vedantic tradition, which emphasizes the importance of spiritual growth and self-realization, Atmanang Moksha, and also working for the betterment of society and the world, Jagat Hitayo. It is a wonderful philosophy that encourages individuals to strive for their own spiritual liberation while also contributing to the greater good of humanity. Swami Atma Priyananda Ji embodies this spirit of selfless service and spiritual pursuit. সারস্বত সাধনা, অধ্যাত্ম চেতনা এবং সেবা ধর্ম, এই তিন মহৎ গুণের সমন্বয়ের মূর্ত প্রতীক স্বামী আত্মপ্রিয়ানন্দজি. Ladies and gentlemen, with this brief introductory note, I welcome Swami Atma Priyanandaji Maharaj to the podium. We are also happy to have with us Brahmachari Manasdeep Maharaj, who is a PhD in biotechnology and one of the principal academic coordinators of Ramakrishna Mission Vivekananda Educational and Research Institute. Swami Atma Priyanandaji.
So may I begin with a Shanti Mantra. Shanti Mantras are peace chants which are prefixed and suffixed to every Upanishad, which is called Vedanta. Now the world has everything, and the pace at which technology is progressing, people are afraid that artificial intelligence may overtake the human intelligence. But what the world woefully lacks is peace. Everybody is fighting with everybody else. For what, nobody knows. If you have a purpose to fight, there is some meaning in that. So you just fight, you take others' property, kill people, and the whole world is looking on helplessly. The United Nations organizations, which was created to bring peace to the world, is also helplessly looking on. Somebody asked me, what is the greatest problem plaguing the whole world? In Bengali I said, Anirvachaniya Ashahayata, inexplicable helplessness. Everybody feels I'm helpless. If you ask a person with a lower strata, so what can I do? The big boss doesn't allow this. If you ask the big boss, what can I do? My colleagues don't cooperate. So everybody is helpless. I don't know why the whole world is suffering from terrible helplessness. In spite of knowing what they should do, in spite of having the capacity that they should do what they should do, there's a tremendous asahayata, helplessness in the human heart. In such a situation, our ancient rishis always spoke about peace, chanted the Shanti Mantras all the time before they begin the study. So let me also follow the same tradition. This is about universal peace from the Vedas, supposed to be 5,000-6,000 years old. Om Dyo Shantihi Antarikshagam Shantihi Prithvi Shantihi Apash Shantihi Oshadaya Shantihi Vishve Deva Shantihi Brahma Shantihi Sarvam Shantihi Shantireva Shantihi Sama Shantiredhi. May the heavens be peaceful. May the interstellar space be filled with peace. May the earth be peaceful. May all the water bodies, the rivers and the oceans be peaceful. May the vegetation be peaceful. May the environment be peaceful. May all the animals and all the living species in the world be peaceful. May peace pervade everywhere. Natural forces be peaceful and the human heart be peaceful. Let that supreme peace, whose source is the supreme being, fill us all. Om, peace, peace, peace. So
continues to unfold two parallel sessions. So in case you are keen to hear the mini oral presentations, I must tell you, you are in the wrong hall. And you have little window to escape before we start the sessions here, which would focus on precursor lesions. May I invite the chairpersons for this session. My pleasure to invite Professor Dr. Hemant Malhotra, who is the head of medical oncology at Sri Ram Cancer Center and Mahatma Gandhi Medical College, Jaipur. I also have the pleasure to invite Dr. Ankita Sen, who is a clinical hematologist at Chittaranjan National Cancer Medical Institute of Kolkata. So the stage is all yours. I would request you to invite the speaker.
Introduced to Dr. Shaji Kumar. He is a professor of hematology at Mayo Clinic in Rochester. He's a true India lover, and he's here for most of our hematology and myeloma conferences, and world leader in myeloma, and we look forward to hearing him. Over to you, Shaji.
Thank you, Dr. Malhotra and Dr. Sen and everybody else for being here. So what I'm going to try and do, and the whole concept of a pre-malignant phase in multiple myeloma and related disorders, and make a case for why we need to identify them and what can we do about it if we identify these patients with precursor conditions. So I think it's important to first get a sense of, or keep in mind, the whole complex spectrum of monoclonal gammopathies that we deal with in our patients. Now, at the core, the basic minimum that we need for diagnosis of monoclonal gammopathy, as you all have heard so far, is a clonal proliferation of plasma cells with or without a monoclonal protein typically detected in the serum or urine. Now, that definition of monoclonal gammopathy encompasses a huge number of conditions. Obviously, the most common ones that we talk about as the earliest phase or earliest diagnosable phase of this plasma cell proliferative disorder is the monoclonal gammopathy of undetermined significance. Now, they can be broadly classified into an non-IgM MUGUS, which is the most common type, or an IgM MUGUS, or a light chain monoclonal gammopathy of undetermined significance. Then, of course, patients can also present with plasmacytoma that is isolated. But the monoclonal gammopathies of undetermined significance is something that we don't typically treat unless they actually cause some problems, which would be the monoclonal gammopathies of clinical significance, which you will hear from Dr. Jagannath later today. Now, all these monoclonal gammopathies of undetermined significance, they can be an intervening phase between the MUGUS phase and the active disease phase. And in case of IgM MUGUS, it would be a smoldering Waldenstrom and then Waldenstrom macroglobulinemia. Now, the non-IgM MUGUS, whether it be light chain MUGUS or the non-IgM, they can actually go on to, of course, develop light chain amyloidosis without any intervening phase, but they can also develop smoldering multiple myeloma, which we will talk about in a second here, before they actually develop multiple myeloma or active myeloma. And similarly, the plasmacytomas can also go directly to, again, developing multiple myeloma without necessarily having a smoldering myeloma phase. So it basically gives us kind of couple of different opportunities or to intervene before patients develop active disease. And then there's obviously monoclonal gammopathies of clinical significance where they haven't quite met the criteria for myeloma, but there's clearly evidence of end organ damage, which means you have to do something about the clone. Now, looking at from a multiple myeloma perspective, we know that there is the monoclonal gammopathy of undetermined significance, a smoldering myeloma in between in majority of the patients, which may or may not be detected or identified as such before they get diagnosed with multiple myeloma. But what does qualify this progression is increasing levels of monoclonal protein, increasing plasma cell percentage in the bone marrow, and then development of end organ damage. But in addition, there are other changes like what Dr. Munshi is going to be talking about in terms of gradual change in the immune microenvironment as well. Now, in terms of the definitions, there have been some modifications, especially in the context of smoldering multiple myeloma with the most recent revision back in 2016. But the MUGUS definition really hasn't changed. It is really a low clonal burden plasma cell disorder with, again, M spike that is less than 3 grams bone marrow, less than 10% plasma cells, and less than half a gram of M protein in the urine, and no end-organ damage. Now, the smoldering myeloma, the main difference is increasing burden. So you have more than 3 grams of M spike, or you have 60%, up to 60%, up to 59% of clonal plasma cells. Now, one thing we do know, and which seems very easy to guess, is that all myelomas are preceded by a monoclonal gammopathy of undetermined significance. Now, it is not just an assumption. This has actually been proven by using stored samples from a large study done on a PLCO study in US, where they looked at samples that were banked before the diagnosis of myeloma, and they were able to demonstrate that nearly 90+% of these patients had a monoclonal protein identified up to 8+ years before the diagnosis of active myeloma. But at the same time, we also know that not all patients with monoclonal gammopathy of undetermined significance actually get active myeloma. In fact, only about 20% of patients over the lifetime will develop active multiple myeloma. Now, the question is, why is this all relevant, right? So just as, increasingly there's emphasis in cancer to try and prevent the cancer from happening rather than trying to treat the cancer. And here we have a disease where we have an opportunity to intervene because we have a long precursor phase, probably 10 to 15 or 20 years before the patients get myeloma from the time the clone starts. So can we cure myeloma, or can we prevent myeloma, or can we at the minimum delay myeloma? And this is an opportunity to do so. But in order to do that, we really need to identify the patients who have these monoclonal gammopathies. So there has to be some type of screening. But obviously, for a screening to be effective, we have to have tests that are very sensitive, but also very specific, so that we don't over-treat patients. But we also have to have interventions that are safe, and also that alters the natural history of the disease. We just don't want to give a treatment that will just change the protein levels. We actually want to make sure these patients are going to be living longer by intervening early. And these are principles that are not unique to myeloma. It's applicable to any form of cancer where there's a precursor phase that we can intervene in. Now, one thing that is very clear is if you look at databases from large institutions, like this is a Mayo data, only about 57% of the patients that we see in the clinic have monoclonal gammopathy of undetermined significance. But we do know that if we just go out and look in the community and screen for monoclonal proteins, probably 90% of the patients with monoclonal protein or more will have monoclonal gammopathy of undetermined significance. So clearly this is biased when you look, because patients actually showed up for some symptoms in the vast majority of the cases. So it's very important for us to, in order to get a sense of what is the true prevalence of monoclonal gammopathies, we really have to do population-based screening studies. So I'm going to talk about 3 different studies which I think has given us important information. One of the very first studies was done by Professor Kyle in Olmsted County, which is where Mayo Clinic is, the city of Rochester. And he actually sampled 21,000 of the 28,000 residents who are over 50 years. Some of these were already known, so they were incorporated into the cohort, but the patients, and some patients, a majority of the patients had come to the clinic for something, so there was a blood sample available. And where the blood samples were not available, they were prospectively contacted and samples obtained in order to screen for monoclonal protein. And the testing was done with serum protein electrophoresis and immunofixation studies. And you can see here that when you look at the percentages of the total percentages, you can see that there's an age-related increase in terms of the prevalence of monoclonal gammopathies, to the extent that if you are over 80 years of age, nearly 6.6% of this population will actually have a monoclonal protein that is detectable with SPEP or immunofixation. And clearly there's an increase over age, but also an predominance in men over women, and that reflects even what we see in myeloma. About 60% of the myeloma we see are men and 40% are women. Now, when you look at the characteristics of these monoclonal gammopathies that were detected, you can again see that majority of them were IgG, similar to what we see in myeloma. But again, we do see a significant number of IgM MUGUS, about 17%, but in myeloma it's rarely 1 to 2% or less than 1%, which is IgM myeloma. So obviously these IgM MUGUS, many of them go different route in terms of getting Waldenstrom's, amyloid, and other related disorders. Now, the next study, so the study that was done by Professor Kyle kind of set the stage for what is thought to be the prevalence of monoclonal gammopathies in the Western population, the Caucasian population, which is roughly about 3% if you look at the entire population over 50 years of age. The second large study that was done in the Iceland, called the ISTOP study, where they literally screened almost 75,000 individuals in the community, which over 40 years of age, which represents most of the population in that country. It's easy to do because they have a nationalized health system and also is geographically very confined. But this study took asked the next question. If the prevalence is so, does it make a difference in if you actually detect the monoclonal gammopathy? Are we able to do something about it? So their question was not as much the intervention as much as how significant or how in-depth workup is needed if you detect a monoclonal protein. So they identified patients with monoclonal gammopathy and then randomized them into 3 groups. One where they did nothing else, what we were currently doing, just watching them. The second was to do, again, some additional follow-up, which is much more stricter. And the third arm, actually, they did a more intensive workup, including bone marrow biopsies. So what they found was that if you do more detailed workup and you watch them much more closely, you are going to identify more patients with smoldering multiple myeloma, more patients who actually have myeloma, and also more patients with amyloidosis. And if you do more intense workup, including a bone marrow biopsy, you're going to find even more patients. So essentially, some of these patients with MGOs are going to get reclassified as having smoldering myeloma if you do more intense workup. So what they found in their study was that if you look at the overall cohort, the prevalence of monoclonal gammopathy in this patient population over 40 years of age was roughly about 4%. But you can also see that the similar findings in terms of more, the higher prevalence among the males compared to the females, but also an age-dependent increase in the prevalence of monoclonal gammopathies. So these findings were quite similar to what was found in the Olmsted County study by Professor Kyle in terms of the numbers, roughly about 3 to 4% prevalence that increases with age and higher in men. Now, a couple of additional important findings from the ISTOP-MM, and this is a study that is continuing to be followed, so we will continue to learn more about these conditions. So one of the findings was with the more intense workup and intense follow-up, you are identifying more patients who are transitioning from monoclonal gammopathy, MGUS, to smoldering myeloma or smoldering Waldenstrom's. So obviously it's intuitive. You look at things more closely and more frequently, you're going to find more things that are transitioning from one phase to the other. The more important question, I think, is how are you identifying more patients with myeloma by using this approach? The interesting finding here was, as we can see, the first 3 to 4 years, you identify more patients with progression to myeloma, but you actually find less of the patients progressing to myeloma beyond 4 years, suggesting that this is more of a time bias phenomenon. The people who are actually going to get myeloma, you just identifying them more early by an early intervention, not intervention just from the point of view of diagnostics. So I think that is an important point, but the ultimate goal of this study is to see, are we detecting, if you detect monoclonal gammopathies early and myeloma early and intervene early, are we going to improve the survival of these patients? That is the gold standard for deciding whether screening is a appropriate approach. Now, one other important data that came out of the ISTOP-MM study is the prevalence of light chain monoclonal gammopathy of undetermined significance. We had looked at the Olmsted cohort and determined that the prevalence was about 1.5%, but subsequently there have been studies looking in the ISTOP-MM study. They used a definition or normal range for free light chain that was wider, and they think the prevalence is more in the range of 0.26%. Now, a couple other important things to remember. The MGUS starts early. We think, based on some of the modeling studies as well as some of the more recent genomic studies, that the MGUS clone probably starts in the second decade of life for the vast majority of the individuals and then slowly increase over time. The second important thing is the vast majority of the patients with monoclonal gammopathies remain undetected clinically. They can only be detected by using screening. As you can see here, a significant gap between the two. Now, how do we increase the sensitivity of the testing we use, right? So one of the technology that has become available is the mass spectrometry, and you heard about this yesterday from Nikita as well. You can see that the prevalence in the Olmsted County study, without using mass spectrometry, it was 3.5%. But using a mass spectrometry, we can identify the prevalence as about 5%. So that certainly increase that. And if you use a more sensitive mass spectrometry, you can go up to 6 to 7%. Now, that brings us to the third study. The question is, who do we need to screen, right? So if you screen the entire population, even over 40, you're still going to find about maybe 4 to 5% of patients with monoclonal gammopathy of undetermined significance, and the vast majority, we are not going to do anything. So I think the approach for the future is going to be looking at a more enriched approach. Who are the people with the highest risk of getting monoclonal gammopathy, and then only screen those patients. So the PROMISE study was a similar study that is, again, not a truly screening study because it used a mix of biobank cohorts as well as some patients who were prospectively enrolled. But the goal was to see what is the prevalence amongst patients with high risk, defined as either African Americans who have a 3-fold higher risk, or patients with family history who also have a 2 to 3-fold higher risk of getting monoclonal gammopathies. What they found was that the MUGUS prevalence, using again similar methodology like what was used in the Olmsted study and the ISTOP-MM, is about 6%, which is very consistent because you're looking at about twice as many, 3% versus 6%. If you use a mass spectrometry-based approaches, you can certainly find more. But one of the findings from this study, as well as what we have seen in our own study, is that using mass spectrometry, you can detect a lot of patients with small IgM spikes where the risk of progression is practically zero, and those patients really should not be classified as monoclonal gammopathy of undetermined significance. And again, this is just showing the same number. If you focus on those patients with monoclonal gammopathy of MUGUS detected traditional methods, you can see that there's an increase in prevalence over time. And I think it's important for us to define the natural history because that is going to set the stage for the need for defining the need for intervention as well. Now, one thing to keep in mind is that MGUS, and I think Dr. Rajkumar will allude to this as well, is that MGUS, even without progression to active plasma cell proliferative disorders, is associated with some decrease in the overall survival for all the reasons of which is not very clear. Now, finally, I think, monoclonal gammopathy of undetermined significance, given the low risk of progression, is probably not the best place for us to do intervention studies. We really want to look at a population that has a high risk of progression to myeloma, and the natural cohort that is there is a group of patients with smoldering multiple myeloma. And we know the natural history of these patients, and the risk of progression is almost 70% or 60% over 10 to 15 years from the time of diagnosis, and almost 40 to 50% over the first 5 years. So clearly a group of patients where we can certainly consider intervention. And the type of intervention is Dr. Rajkumar is going to talk about that. But from the ISTOP-MM, we think the prevalence of smoldering is about 0.53%, and again, just like MGUS, it increases with age. And this is the natural history of smoldering myeloma based on a large cohort of patients from the International Myeloma Working Group study. 20% progression over the first 2 years, 40% over the first 5 years, and about 60% will progress over the first 10 years. And these are the benchmarks that we use for calculating the benefit from all those intervention studies. So I would like to conclude by saying, again, monoclonal gammopathies, at least in the Western population, is roughly about 3% using older methods, up to 5% by using mass spectrometry-based methods. Risk is twice as high in African Americans and patients with first-degree relatives of individuals with monoclonal gammopathies. Currently, we don't recommend routine screen. I think we can make a case for screening the high-risk patient population. We don't know yet. Identifying them early and watching them much more closely is going to change the outcome. The ISTOP-MM study will tell us that. But what we do know is the patients with smoldering myeloma with a high risk of progression, now with our studies showing that there is going to be benefit in terms of improvement in outcomes. So I'll stop there and happy to take any questions.
Thank you, sir. That was a really good insight into something which we normally find as an incidental finding. To the organizers, can I ask a question before we proceed to the next speaker?
Yeah.
Okay, so my question to you is, like you mentioned, Iceland is a much smaller country. How do you see the feasibility of doing such a trial for picking up MGUS patients in a country like ours? Like, which would be the ideal population to scan?
So I think it's important for us to kind of define the I think what we have done in the Olmsted County, for example, I mean, it has to be a population-based screening. I think that's the most important thing. The Iceland is convenient because of the health system they had and it's geographically located. It also has a disadvantage because they're a very homogeneous population from a gene pool standard. Now, in India, I think there's much more heterogeneity. So I think it's important for us to do these studies in multiple different geographical areas within India, given the differences amongst the population. But at each location, I think the important thing is to do a systematic sampling of the population. And again, I think most of the Western studies have looked at individuals over 40, but India may be one place where we may want to start thinking about screening even a slightly younger population, given the median age of onset of myeloma seems to be a decade earlier.
That brings me to the second part. So if we are screening, in that case, how often, so we would have to counsel the patient, that would be an extra burden of tests. So you mentioned we would just go for SPEP and serum free light chain. So how often would we keep following up for that patient?
So if you identify, so important thing is once you screen and you identify there's a monoclonal gammopathy and you do the appropriate classification, if it's a MGUS, based on the risk, you might follow them maybe every year to maybe some of the very small M spikes, we tell them we don't even follow them. Obviously, if they have smoldering myeloma, we would need them to be followed much more closely. But the important thing is also, I didn't present the data, we have data from the Olmsted County where we've shown that if you are 50 years of age, 50 to 60 years of age, and you do a mass spectrometry and it's negative, your risk of getting myeloma in the next 20 years is almost zero. So you can literally do a one-time screen when you turn 50. Maybe the population yet to be defined, maybe a high-risk patient population. When you do turn 50, you do a bunch of different screens, right? So at that time, you do a mass spec-based testing, and if it's negative, you don't have to worry about it for the next 20 years or so.
So any other question, comments from the audience? Yes, Ajay? Can somebody give him a mic, please? Thank you.
Thank you, sir. What is the primary endpoint for this MGUS population for any designing the clinical trial?
Ideally, we want to improve their overall survival, right? But it's going to be hard to do that kind of studies in this patient population. So I think we can look at a variety of other things like the need of myeloma therapy and need of active intervention could be another endpoint. But the other important things that have been studied, for example, in ISTOP-MM is the psychological impact of screening, right? Knowing that you might have a monoclonal gammopathy, what does it do to their social kind of well-being, mental well-being? And apparently from that ISTOP study, it doesn't seem to have any psychological impact from the screening studies itself. So again, I think the endpoint, ideal thing is any screening and intervention should be associated with improved survival. And I think Dr. Rajkumar is going to tell us about the smoldering myeloma patient population.
Thank you, sir.
Okay, last question.
Just was thinking about loud about the consequences of being labeled as an MGUS when we do a screening program. I just want to know, like, if somebody is picked up as an MGUS or maybe a smoldering, what is your recommendation? The questions which come to my mind is, if it is a young person who is being screened, can he be a prospective donor for blood and marrow? What would be your take on that? Is there any evidence to say?
It's a good question. I think, when you think about screening, the majority of the work or the bulk of the explanation has to happen before you do the test, because patients really need to know what they are getting. Otherwise, it's going to be more regret than actually benefit. So once you know that there's a monoclonal gammopathy, I think the standard guidelines apply. Most of those patients with any precursor cancers, we generally don't recommend any kind of tissue donation of any kind.
Thank you.
Okay, thank you so much. So may I now invite our next speaker, Dr. Nikhil Munshi. Dr. Munshi again needs no introduction to this august audience. Sir, please proceed.
Thank you so much, and thank you, Dr. Nair and the organizers for having us here. I think coming to this meeting in January every year has become a fixture that we all look forward to and interact with everyone. I'm going to talk on the next part of this precursor disease about what changes as far as the immune function is concerned. These are the disclosures. So there is myeloma is a disease of plasma cells. Obviously, immune system is involved. It's a disease of immune system. And there are a lot of background that clearly suggests the relationship between the two. There's been good publications showing that a chronic antigen stimulation of plasma cells may be connected with eventual development of myeloma. One of the publications was that the lysolipids, anti-lysolipid antibodies, are observed in 1/3 of the patient with myeloma. It might be more depending upon how you measure. So there's a clear connection with that, with repeated infections, with chronic inflammation, with autoimmune disorders, frequency of MGUS smoldering, and eventually myeloma is significantly high. So there is a very good connection with that. There is a case report almost 40 plus years ago, close to 50 years ago, which is, or maybe even longer, which is very illustrative of what can happen. So this patient got a horse anti-serum against tetanus in old days when patient developed tetanus. Years down the line, patient developed MGUS. And the IgG component of this patient was specifically reactive to horse alpha-2 macroglobulin. It could have only come because the patient was exposed to the horse antiserum. And obviously, the plasma cell stimulation eventually led to development of MGUS. The patient eventually developed myeloma 30 years later and then was treated for it. But the point that this case illustrates is that antigenic stimulation may have some relation. It doesn't cause it, but there's a plasma cell which got converted. So when myeloma develops from early disease, and when the early disease develops from normal plasma cells, few changes happen in the immune system. One part of the system change is that there is an augmentation of tumor-promoting immune responses, and that has become quite an important focus for all of us. There are cells in the immune system like plasmacytoid dendritic cell, various macrophage component, not just MDSCs, but various macrophage component, as you would see, are connected with tumor promotion. Same way, inflammatory condition is part of the macrophage activation quite often. And then there are T cells, which are also tumor promoting, Th17 cells producing IL-17, IL-22, etc. And the second component in the immune system happens is that there's a suppression of tumor-protecting immune responses. Normally, immune responses would prevent tumor from developing, but those are suppressed by various mechanisms, includes T cells, B cell, NKT cells, and various other subfractions of that, Th9, TFH, etc. So both of these processes, augmenting the tumor as well as suppressing the anti-tumor effect, happen in the tumor into the bone marrow to support progression of smoldering myeloma, MGUS, to eventually developing myeloma. One example is the abnormal B cell subsets in myeloma. So B2 cells, and I'll just focus on one, are the cells which are important for eventually making antibody. And what you would see that in myeloma, it's very well known that uninvolved immunoglobulin are suppressed. You don't see very good antibody responses. If patient has IgG myeloma, IgA and IgM are suppressed. It's because of the decrease in the B2 component. And so you could see that in myeloma compared to healthy donor, B2 cells are significantly low, both in bone marrow and both in peripheral blood. And this is just one example of how this suppression may be driving some of the processes in the disease. Another good example published a few years ago by a good friend, Dr. Zodapkar, was that patients who have this anti-SOX2 T cells, either absent or present, will determine if a patient is going to progress from early disease, from smoldering myeloma to myeloma. The blue curve are the patients who do not have the SOX2, anti-SOX2 T cells, and they have a much higher frequency of progression. So losing the T cell function also might be indicative of likelihood of progression. So if we put it together to see what contributes an MGUS progressing to myeloma, there are a number of changes in the bone marrow microenvironment. And they're all summarized in this very complex slide, which basically are again divided into tumor-promoting cells, which are augmented during the transition to the progression, and tumor-suppressing cells, which are, on the other hand, down-regulated. And combination of these two, in some sequence, may be driving the disease. So as in the more recent time, these are all less specific changes are further delineated by using single cell and other technologies. What is found is that there is a clearly decrease in memory T cells, increase in the terminal effector cells, in MGUS and myeloma both, although the differences are different between the two conditions. So for example, if you look at MGUS cells, this TCF expressing CD8 cells, TCF is a transcription factor which is important for T cell stemness. T stem cells they are suppressed in MGUS. Eventually, they are increased. The TCF negative cells are significantly increased when transition happens to myeloma. So translating into our practical thing, these changes, decrease in the memory cells, increase in the T effector cell happens, that is connected with the progression. And all of this will tie together to see how we can utilize for our day-to-day practice. The second thing is that all these alterations in microenvironment, they occur early in the myeloma progression. So the cartoon on the right side here is illustrative. So the NK cells changes, macrophage changes, T regulatory cells dysregulation, they all happen at an MGUS stage, which is then progresses to smoldering, where some of the compositional changes comes about, memory T cells comes about, and when myeloma develops, right at the newly diagnosed stage, these cytokine inflammatory responses come up. So we have to look for these changes in the immune system to understand if there is a progression and where it is going. And so if you put it in a cartoon fashion, in MGUS you see these early changes, that then translates into smoldering stage where you can see the CD8 and memory component of the T cells changing, both CD8 and CD4, and eventually cytokine response that comes up in myeloma. So this is the progression, and as we do immune profiling, we should look for some of these changes to guide us. Now, if we go to summarizing it from a different angle, and this was single cell analysis done, which also confirms, and this is a separate study from what I just showed you, is that there's a decrease in this memory and naive CD4 T cells and increased T regulatory cells. Number of colleagues here work on allogeneic transplant, where T regulatory cells play an important role in controlling GVH, in controlling various function. So looking for these changes are going to be important. And the practical aspect of this is what I would show this study that was done a few years ago, where patients with smoldering myeloma, MGUS, and myeloma were randomized to receiving placebo versus lenalidomide. And then the patients were vaccinated against hepatitis B. Hepatitis B vaccine is given on day 1 month or 28 days, and at 6 months. So they got 3 hepatitis vaccine. These were all hepatitis B negative patients, so they were not exposed to hepatitis B. And looking at anti-hepatitis B responses was the endpoint. The study was to see whether lenalidomide would augment this. And I'll give you the punchline first. Lenalidomide did not make a difference if the vaccine response increases or not. But for today's discussion, the findings from these studies were very interesting. What we observed was that patients got vaccinated. Not everybody finished for various reasons. There were 21 patients who got Len, 16 got placebo. However, if you look at the response, only 7 patients out of these 32 developed anti-hepatitis B vaccine response. The responses were not more in MGUS, and they were similar as myeloma. As you can see, Len did not make any significant impact, and the surface antibody titer, even in responding patient, was relatively low. So if you put it together and compare with general data available in the literature, Hep B vaccine response has been widely published. in normal population. You could see that when a normal healthy volunteer, and there were 600 volunteers here, who got vaccinated with hepatitis B, 86% patients responded. The titer goes above 1,000, 13% did not. So very small number. On the contrary, on our side, myeloma MGUS side, you could see that 68% did not respond to vaccine at all, 31 did with a low titer. And this is all patient population. And if you look at MGUS patient, very similar. 76% did not respond to vaccine. So immune dysfunction starts very early and may have some relationship about how the disease progresses. One other thing we looked at, why did patients not respond? And clearly, the antibody response is a B cell response. But it may originate from the T cell response. So they do not even have what is called pentamer positive CD8 cells. They did not have hepatitis B specific T cell responses. So their immune function, even in MGUS patient, is significantly impacted. And when you look at all these changes with the memory T cell and other, it is clear that patients who do have T cell phenotype which is favorable, they have a better overall survival. So when patients develop myeloma, their outcome also is impacted by all T cell function. Coming to today's world, T cell phenotype influences responses to anti-BCMA, and we have to keep that in mind. I will not go into detail of that. Dr. Rajip tomorrow would be discussing some of these features. However, if you look at one of the newer phenomenon that is being evaluated is that when myeloma, from MGUS it becomes myeloma, the immune surveillance disappears. And very new concept is of immune aging. The T cell in a given patient would feel and act old and do not function as well. And that is one of the genesis of the disease there. So it's a complex algorithm to study it. There are 19 markers which we can utilize to tell the immunologic age of the patient. And so when we look at MGUS patient and myeloma patient, the chronological age is very similar, but immune score, the immune age, is much higher in myeloma compared to MGUS. So when the immune age changes, you can predict the myeloma that the MGUS patient or smoldering patient may be now drifting towards progression to the disease. And this maladaptive immune aging is a very important factor to keep in mind now as we do a lot of manipulation in this patient. One, looking at transformation. There is some racial differences, so we don't know what would be in the Indian population, but that's something to be looked at. And the malignant transformation is associated with the transformation of immune aging. So that was one of the markers to keep in mind. And the second part of this maladaptation is that there is significant spatial differences. We discussed a lot of cases today where patients had come up with focal lesions. And what is seen in the lab on the immune side is that in MGUS you don't see clusters. The plasma cells in low number are spread around the bone marrow. In myeloma, you would see patches. And that patches come up because the myeloma cells prevent the immune cells from going in and allowing the myeloma cells to grow further without immune inhibition. So these spatial differences play an important role. So what is the significance? One thing, this kind of aging process and the spatial differences allows the progression to myeloma. For practical purpose for us in the clinic, it may allow us to maybe reverse the immune aging. That may prevent the progression. It may also provide better basis for doing immune-based therapies in future. And by allowing the T cells to go to those spatial lesions, maybe we can also treat the extramedullary disease more effectively. So immune aging, progression, and prevention of progression would be the part of this. And so finally, can we study this in patients to predict who is going to progress when? The answer is that it's complex. Which component do we study? T cell, B cell, and all different other various components. Immune assays, they're markers of prognosis. We can utilize them. Single sequencing is beginning to help, and I think that's going to become our mainstay. But it's not just the number. We need to look at the functional aspect, which is what is seen when we look at the immune aging. And so immune aging looks at number and functions together. So stay tuned for looking for how do we estimate immune aging and at what age, immune age, would one be considered high risk for progression or not, and then we can look at the spatial distribution of this. So to conclude, I think immune system plays a great role. However, one thing, and that's a number 3 bullet, the cause and effect association remains unclear. Is the immune system changing because of the progression, or is it causing the progression? The likely answer is both. It is connected with causation, but also it may be related with the causation. So I would think I will stop there and take questions. Thank you so much. These are the people in my group who
Thank you very
does
much,
the work.
Dr. Munshi. Wonderful talk. Yes.
Morning. Wonderful concepts. I wanted to know, see, if you are about to check the normal ranges for different immune cells in healthy population, there is a wide variation. And so here, do you think that it's rather the functional capacity of these cells rather than the numbers which make a difference?
Absolutely. That the function is more critically important. Numbers are not. We have studied numbers till today or yesterday because that's all we could do well. Now with functional genomics, with single cell analysis, stimulate the cells and look at various transcriptomic changes, we can look at the function. So 100%, I think functional component is more important. You may have a lot of cells, but not functioning. They may not be as important, and that's where this aging concept comes. You could argue aging is a fancy name for T cell exhaustion. It could be fancy name for PD-L1 or PD-1 expressing cell, but still, that's a functional component.
So the second aspect is that we've seen that during progression within myeloma and from MGUS to SMM and to myeloma, people have shown that there are functional differences as well as the numerical differences, especially for the NK cells and NKT cells. So far we've been using immunomodulatory drugs, so perhaps they are making it, that's how they are acting and making a change. But do you think that specific therapies to boost these immune cells is in the pipeline, or do you have insight on something like that?
I very much think so. For cancer in general, the checkpoint inhibitors, for example, are doing partly that. They are changing the immune age to younger age, you could say, in a different way. In myeloma, we had a setback in the old days, 10, 12 years ago, when checkpoint inhibitor has issue, but it's researching. There was a publication just came out a week ago or two where PD-1 inhibitors were utilized for post-CAR T cell relapses to see if they can be rescued. So I think changing the function by drug is going to be an important component. In different ways, producing CAR T cell in vitro and then injecting is also almost that we are changing the function and providing it. The best example is that all this dysfunction, when the cells are taken out and cultured in normal environment, they start behaving normally. And so it is the environment that makes them abnormal, and when they're out, they're better, and then you can give it back. And so I think learning some of this is going to improve how we co-opt the immune responses.
Thank you.
Dr. Joseph.
Yeah, thank you very much for the elegant presentation. So you have shown that there is T cell dysfunction which is causing the poor immune responses in hepatitis B, and extrapolating that, I mean this is an MGUS, and extrapolating that to even myeloma, we assume even profound T cell dysfunction. And on one side we are propagating this vaccination pre-treatment and then going ahead. So how do you want to place the immunization, vaccination process with this insight which we have?
That's an excellent question. I think that giving it, is it good to give it before or is it good to give after? And the only reason the concept of giving it before has come about is that we don't know what our treatment does. When we give high-dose melphalan, we are significantly impacting T cells, causing more impact on the immune system, etc. I think the critical bottom line I would say is that when we vaccinate patients, and there have been literally many good publications COVID time to see what does the COVID vaccination mean in this patient. And the bottom line and these are all myeloma focused papers, but the bottom line is that giving vaccination and thinking it has worked is not a good idea. We need to try and check whenever we can do it everywhere. We need to check if the vaccine had an effect. So if COVID-19 vaccine is given and you do see the antibody titer go up, I think then we know it has worked. Similarly, for some of the other vaccination, some vaccination we cannot do it in the lab, yes, but not in practice. And then we have to hope that it has worked, but still take precautions.
Thank you.
Yeah, last question, please.
So, Dr. Munshi's very nice concept, and we are also working for some time on the immunology. Now, taking from myeloma, means MGUS to myeloma, let's go a little bit ahead. And there is a paper from the Ola's group. He said that sustained MRD negativity versus MRD relapse, means a loss of MRD negativity. Also, the immune reconstitution has significant role on it, the Nature Communication publication. What is your thought process on that? Because not all MRD positive patient relapses.
Yeah, so I think having immune function improve is a good thing. And in an eventual definition of cure, and we'll talk about later in the day today, it might come where myeloma should go away, the immune system should improve. But the immune deficiency is not just disease, as I said, it's treatment, it's a lot of other things. So not achieving full immune recovery, to me, does not mean there is still presence of disease. I think there is just residual effect of what we did, and we may have to live with it. So sustained MRD negativity, of course, it's, I think, important. We all strive for it. But improvement in immune function, although desired, may not be achieved for various other reasons.
Do you think there's a role of immune system maintaining MRD, sustained MRD negativity versus loss of MRD negativity?
I personally don't think so. I think the role immune system plays at that point may or may not be. It's more driven by the genomics of the disease, the residual cell, etc. It is true that when disease is low, and depending upon what the treatment was done, so if, for example, patient did get CAR T cell and has sustained MRD negativity for 3+ years, it's possible those CAR T cells are contributing. So the answer is not absolute for everything. But if post-transplant patient has sustained MRD negativity, what role the immune function plays would remain questionable.
I think we need to move on. Thank you, Dr.
Thank you.
Munshi. Another round of applause for Dr. Munshi, please. So we'll move on in the session, and the next talk is by Dr. Vincent Rajkumar, and he is going to talk to us on can intervention prevent progression to myeloma, ongoing clinical trials for smoldering myeloma. And you know, these 6 or 7 gentlemen and ladies who come from the US, in the US they are known as the US Indian myeloma mafia. Not my term, but I've heard it in several international conferences, and one of the godfathers of this mafia is Dr. Vincent Rajkumar, and we're waiting to hear from you. Over to you, Dr. Vincent.
Okay, thank you so much for having me, and it's always a pleasure to be back at the IMAGE meeting. Today's talk is on smoldering multiple myeloma, and I've said that this field has become more controversial than anything else in multiple myeloma. And a lot of the controversy in smoldering myeloma is coming from one set of people who have a lot of misconceptions of what the term means. Some people who want to treat it like myeloma with VRD, DARA, VRD, and the whole thing. And then some people who want to just not do anything and just watch the same patients that someone else will treat. And it's been quite a journey for me. I think what the story I'll tell you today, for which many of these trials I've been involved with, is almost the same as my whole career in the field. And a lot of it is because of Bob Kyle. Bob Kyle coined the term smoldering multiple myeloma in 1980. And I was fortunate to work with him and be a co-author on the landmark paper that showed that 10% of patients with smoldering multiple myeloma progress each year to multiple myeloma. That's very different than MGUS, where only 1% of patients progress. And you hear people like, let's just club the MGUS and the low-risk smoldering myeloma together. That's really not helpful to our patients. Our patients need to know what each thing means. And if you say they have an MGUS, you're talking about a very low risk that they'll ever get myeloma, 1% per year, 10% at 10 years, 20% at 20 years. It's very different than 50-50 chance of getting active disease in 5 years. That's very different than 50-50 chance of getting active disease in 2 years, which is the high-risk smoldering myeloma. So the terminology carries some impact for the counseling. How do you manage these patients? Do you watch them once a year? Do you never watch them? Do you watch them once every 3 months? Do you give them some kind of intervention? Everything differs based on the terminology we use. And I'm not one fond of change. So somebody has called it MGUS. I'm not going to change it to something else just because today I feel a better term would be better. It just causes more problems. I mean, how many of you want to change Hodgkin's disease to something else or non-Hodgkin's disease to something else? We have grown with these terms. They carry a meaning. It is very hard to convert all of the physicians in the world to think of it in a different way. These terms are here. They serve a certain purpose. And so this slide shows you the number one main thing to learn is that when patients don't have much monoclonal protein and they don't have much plasma cells in the marrow, the risk of progression to cancer is very low. It's 1% per year, and even that is a myth because people die of other reasons. So 25 years go by, 25% don't actually turn up with myeloma. Only 10% do because they die of something else. The 1% figure is based on an immortal principle that if they live and see you year after year after year, and they are around 25 years later, well, they would have had a 25% risk, okay? In smoldering myeloma, a very interesting thing happens. In the first 5 years, 10% each year progress to myeloma. After that, they have declared themselves. They already had malignancy, they declared themselves, and then the progression slows down to 3% per year for the next 5 years, and then 1% per year thereafter. So what we are thinking is a major paradigm shift between what is smoldering myeloma. Smoldering is a term that will conjure images like this, where there's a coal that is like smoldering. And in between stage between multiple myeloma on one side and MGUS on the other side. But that's not what it actually is. Smoldering myeloma is a clinical term where we have a patient who has a lot of plasma cells in the marrow, 10%, 20%, 30%, 40%, but they don't have any lytic lesions. They don't have any end organ damage. Who are these people? And what we now know is that half of them actually, even though they have more than 10% plasma cells in the marrow, are actually just MGUS. They will have a progression rate of only 1% per year. And the other half have actually myeloma, and they have all of the features of myeloma, and they will progress, and they will declare themselves in the next year or two. And this is important because now we have various biomarkers by which we can differentiate who is likely to be MGUS and who is likely to be this myeloma. The likely to be MGUS are called low-risk smoldering myeloma, and the likely to be myeloma are called high-risk. No biomarker is perfect. Whether it's genomics, mRNA sequencing, the best pathologists, no one can tell you with certainty that these 50 will have myeloma and these 50 will have MGUS. So we have to play the probability game. And that's what we do anyway, even in myeloma. If you take 100 people with myeloma and give them VRD, well, 70% are progression-free at 4 years. You want to make it 80%, then you have to treat all 100 of them with DARA VRD because you don't know who are the extra 10 people who will get the progression-free. So we are always playing a probability game, and that's what we have to play in smoldering multiple myeloma. So what we found is that if you take patients with very high plasma cell percent, 60% or more, very high light chain ratios, already focal lesions on MRI, then those people have not a 25% per year risk of progression in a year or 10%, or they have a 40% per year, which is 80% in 2 years. And those people we have renamed as multiple myeloma in the diagnostic criteria. But that's a very small number of patients with smoldering myeloma. Hardly 5-10% of patients who are asymptomatic will have 70% plasma cells in the marrow. So the vast majority of smoldering are still in the smoldering myeloma bucket. And what do we do with them? Some of them are like MGUS and they won't progress at all in the next 5-10 years. Some of them are going to progress within the next year or two. And if you reassure them that things will be fine, you're going to be wrong most of the time. And that's what we are trying to capture. And in this IMWG 2019 risk stratification, which basically is a validation of the Mayo 2018, what we found is that when the plasma cells are more than 20% and the light chains are more than 20 for the ratio, and the M spikes more than 2, you have high-risk smoldering multiple myeloma when you have 2 of those 3. Then they have a 50% risk of progression at 2 years. 50 will progress, 50 won't progress. And that kind of probability can be increased further by using cytogenetics on top of it and the actual value. After all, 25% is more than 20, 45% is also more than 20. How many of you will be comfortable with somebody who's got 50% plasma cells in the marrow and 4 grams of M spike just because they don't have lytic lesions? So that probability is accounted for in this scoring system, and you get a much more crisper prediction. The question is, what do we do? What do we do now that we know that we have a group of people who have a fairly high risk of having a serious life-threatening malignancy in a couple of years? Can we do some early intervention that will either prolong life or prolong at least the lytic lesions, renal failure, and end organ damage? And there have been studies done so far, many randomized controlled trials. I actually did the first smoldering trial in 2000, right after thalidomide was discovered by Dr. Barloghi. We then did the thalidomide plus zoledronic acid phase 3 trial. It's been a long journey for me. The first really good smoldering myeloma trial that was done was by Dr. Marivi Mateos in Spain. She compared Len-Dex to observation, and she found that Len-Dex given to high-risk smoldering myeloma. I'm not talking all smoldering myeloma patients, just that high-risk subset, which is 1/3 of smoldering myeloma. You prolong both the time to actual end organ damage, and you also improve overall survival. You would have thought that this paper that was published in 2013, like, I don't know what, my math is bad, 12 years ago, would have changed practice, but it hasn't. Some of us have embraced this and said we are going to do early intervention. Some have embraced it so much that they want to do actual myeloma therapy. And some have said, no, I'm just going to watch my patient forever. I'm not going to treat until they get the end organ damage. And we are caught between these conflicting philosophies. Part of the problem with this trial, why it didn't change practice, was that number one, it didn't have very good imaging at the beginning. So people said a lot of patients who are in this trial actually had myeloma with small lytic lesions. You couldn't pick them up. And that's why, of course, if you don't treat myeloma, they will have problems. And that's what this trial did, and you showed that treatment helps. The other reason is you cannot do regulatory studies with 2 drugs on one side and 0 on the other, because the FDA and the EMA will say, how do I know whether the steroids work or the lenalidomide or both? So you really need to have very clear hypothesis-driven studies where you can convince the regulators. So this didn't change practice as much as we would like. I was then involved with this trial in ECOG with Sagar, Lonial, and others, which is just lenalidomide alone, and we'll randomize patients so that there is no question whether the steroid or len was helpful. We also said, let's image all of these people with PET, CT, MRI to start with, and then we will randomize them to look at whether len improved time to progression and whether len improved overall survival. What we found was lenalidomide, particularly if you take the 20-20-20 high-risk patients, had a 90% reduction in the risk of end organ damage, just lenalidomide alone. And this study has a follow-up that is fairly long. Because our success with myeloma therapy is so much, and this is still a relatively small study, only about 180 patients, we didn't have enough events to see a survival benefit. But we did have a huge sample size to show a progression to myeloma difference. And we felt at that time that that's good enough. If you can delay end organ damage with bone disease or renal failure, and you did not affect the survival, because the len patients actually lived a little longer. There were fewer deaths in the len arm. We are not actually harming them, but we're definitely preventing end organ damage or at least delaying it. And that's good enough. And we should do len alone for 2 years as a standard of care for patients with high-risk smoldering myeloma. Again, you would think that people will embrace that, but they haven't. There are some who do that, some who said, no, why give len? I'll give Dara Len-Dex or Dara VRD, and some say nothing. So that's where we've done, and some who said, like, we won't do any treatment, we tried to show them that observation alone is a bad idea. In Mayo Clinic, good place, great cancer center, when you just follow high-risk smoldering myeloma patients, frequently we're not able to catch the progression on time. The progression, unless you're living with the patient, will happen between the visits, not just you. And even if you see a rise in M spike, you're usually finding some excuse not to treat. The DARA-Aquila study is a landmark study that was presented by Dr. Dimopoulos in the ASH meeting this December. It is the largest smoldering myeloma study with 390 patients. It's international. It randomized patients to 3 years of DARA versus observation alone. And I won't get into the details because the time is running short, but I will tell you it is almost like a grand slam. It is a well-designed study. Every single patient had baseline imaging to make sure they don't have myeloma. Patients were followed every year with advanced imaging. Patients had a bone marrow every 2 years, and they were seen every 3 months in the observation arm to see if we can prevent progression, prevent deaths. And what happened is like the grand slam. I'll start with this. Number one, the time to end organ damage, the time to actual multiple myeloma definition was significantly better or longer with DARA than with observation. The time to needing therapy, because some of you are not going to believe just because I said there's myeloma progression, physicians would treat when they felt like they needed to treat. And so we allowed treatment to start whenever the physician felt treatment was needed. Time to first therapy was also significantly delayed or longer with daratumumab, 50 months not reached versus active monitoring. You can see here most patients' treatment was started earlier for the observation arm. The third was after the progression occurred, the time of PFS2 was also longer with significantly longer with DARA. Overall survival was also significantly better with DARA than with observation. It is 2 times more, nearly 2 times more patients died on the observation arm than the DARA arm in a well-monitored trial, the type of monitoring that is hard to pull off at the Mayo Clinic or in real-life practice. You're not going to be able to do what we did in the observation arm for this trial. And yet we lost 2 times more patients in the observation arm. And the p-value is not reported only because we have pre-specified events that had to be met, so an actual formal comparison of the 2 curves has not been done, but for regulatory reasons. But the hazard ratio tells you that the p-value will be significant. Quality of life was also not impacted. Actually, the lower arm is the observation. I won't say DARA improves quality of life. I will at least tell you DARA doesn't seem to adversely affect. You know you can give DARA VRD to even Cepheus trial over 65 for 3-4 years, and you're not seeing major problems. So with DARA alone for 3 years, the impact on like quality of life or toxicity or deaths, or I don't think we are harming patients by doing this study. We have the side effect thing, and this is something just keep in mind. Yes, there is 40% grade 3 or 4 thromboembolic, treatment-related adverse events with DARA, but there's 30% with observation alone because people in this age group will get a pneumonia, will get problems, and that's what happens. And so the incremental extra grade 3-4 is 10%, and that did not affect mortality. In terms of trials, we have done trials with 1 versus no treatment. Like I told you, these 3 trials, including Aquila. Hopefully with Aquila, we'll get a regulatory approval from the EMEA and from the FDA. Those regulatory trials are necessary because without approval, you cannot treat patients. We are doing strategic trials to see can these patients benefit from a myeloma-like therapy rather than just a DARA alone or a LEN alone type of approach. And those trials are both, one is ongoing, the DARA RD versus RD. The ESA RD versus RD has already completed accrual, and these will read out. And so for those of you who would rather treat them as myelomas, these trials, please wait for those results. You will know whether there's benefit. And the final attempt is, we are not trying to cure any myeloma or smoldering myeloma with these first 2 boxes. Those are trials that need to be done. But in parallel, we are doing trials to see, can we cure myeloma if we really go aggressively after it? And the ASCENT and the CAESAR trials are good examples of that. There is ASCENT-2 and other things being planned. And those are for patients who are willing to take on a huge risk to their lives in the hope that they'll actually be cured. So there's got to be informed consent and everything else. So some people are investigating bispecific, some people are investigating just the myeloma-like regimens, so we will see where that goes. This is my algorithm. I'm not recommending treatment for the 2/3 of smoldering myeloma who are low risk or intermediate risk, but after Aquila trial, there are no more observation versus treatment trials even initiated or ongoing. So if you're going to wait for more data, you will have to wait forever. So I think we have enough data now to treat patients with high-risk smoldering myeloma. You will delay end organ damage. You will most likely improve overall survival, as we have shown with Akila. And the treatment duration is time limited. We are not recommending endless therapy, just 2 to 3 years and stop. This group, of course, I hope no one has any controversy. We treat them as myeloma. I'll stop with this. Thank you.
So thank you, Dr. Rajkumar. Wonderful talk. Questions and comments? Yes, Ajay, you go first, and then Joseph.
So in the Akila trial for the daratumumab for the 3 years, can we re-challenge daratumumab when the actual need for treatment in the multiple myeloma, and what is the response rate after re-challenge dara on dara maintenance in SMM?
So as you know, in this trial, some patients did progress to multiple myeloma after they received DARA or after their observation, and they received just myeloma-like treatment. And when they did that, some of them got DARA, but not all, because DARA was not yet approved. DARA was approved only in more recently for frontline use, and this trial took place before that. But we did not see any adverse effect on the progression-free survival. That's why the PFS2, by just giving them 2 or 3 years of DARA, we didn't lose out anything. But you shouldn't even think like that. You have to think like on an intent-to-treat basis. Using DARA upfront gave you better survival than waiting and using your DARA for future. I'm just saying that even if you did that, there wasn't any impact. But that question doesn't arise if the survival is better.
Thank you, sir.
Yeah, come to the mic, Joseph.
Thank you very much for that wonderful presentation. So I have 2 questions. One is the philosophy of early treatment, prevention, improving survival versus a more conservative treatment algorithm of treat when you have symptoms. Is the philosophies we're clashing here. And you have chosen to treat an early stage on the concept that there is a 40%, 45% chance that a high-risk SMM has a progression of 40% in 2 years. So what is a meaningful risk you would want? So 2-fold questions. One is, what is a meaningful risk you want to mitigate? Is it 45% or 17% is there in intermediate as well? So wouldn't we then tomorrow come and say that also should be treated? Possibility. Second is, aren't we creating a lead time bias here? And how do we want to mitigate that lead time bias for an early diagnosis? So we talked about that in the prostate cancer. An early diagnosis would falsely give you a better survival because you have recruited them earlier. The third level of that question is, DARA 3 years is a 60 lakh proposal for an Indian scenario at least. For a 4 to 5% advantage in the overall survival if you have to show in the Akila trial. How do we want to place that in the current scenario of these thinking?
Okay. Can you just tell me these 3 questions one after the other? Because by the time you come to the third one, what is the first question?
One is it's a meaningful benefit in terms of advantages. We talked about meaningful benefit. Yeah. So here it is meaningful risk mitigation, whether it's 45% or 17% intermediate risk.
Yeah. So when you do a randomized controlled trial and you a priori set this is the group, so in the high risk population that we picked for DARA, that population there is a massive reduction in risk of progression, like 65% reduction in risk of progression or 70%, I'm forgetting. And there's a 50% reduction in the risk of mortality, okay? That's good enough for me. If you do another trial, if you're asking me, should I do this for low-risk smoldering also, that requires a separate trial. We will never advocate treating people unless there is a randomized trial that shows benefit. In this case, we have 3 trials showing delayed end organ damage, and 2 of the 3 trials showing improved survival. At this point, my view is the problem is myeloma, not the myeloma drugs. Okay, the myeloma drugs are safe in this context, and we haven't shown any worry that giving DARA or LEN is going to cause harm. We haven't shown that in the high-risk group. On the other hand, it has the great potential to reduce risk of actual end organ damage. If you think that the same risk would be there for low-risk patients, well, then I have to do a randomized trial and prove that to you. Without that, we would not recommend it. So 2/3 of smoldering myeloma patients who are low risk or intermediate risk, we are not recommending treatment and until somebody does a randomized trial to prove that such things. So 50-50 risk of progression at 2 years is what we would recommend intervention. The second question you asked is lead time bias. Lead time bias is a concept for non-randomized trials. So you take a bunch of prostate cancer patients early and then you say like, oh, they lived longer than the people. When you do a randomized trial, there is no lead time bias. We have taken an intent to treat cohort, you've randomized them blindly, like, you know, 2 groups. One group got observed, one group got DARA. If the DARA groups did better, that's not lead time bias. So that is real. That's why you overcome that with that. The way to overcome lead time bias is a randomized trial. So you have
overcome by the randomized trial.
Exactly.
And the percentage of the overall survival benefit is what exactly was the benefit by giving the DARA?
I told you, 0.52 is the hazard ratio, so it's 48%.
48%.
And if that is in a study which followed people so closely, you really think you'll be able to see smoldering myeloma patients every 3 months with high-risk smoldering myeloma, image them with PET-CT every year, and bone marrow them every 2 years? Okay. And you'll save their lives by doing so compared to that. Now, coming to your third question, it's very important. DARA is a $500,000, I don't know how many $1 million drug, but it's a very, very expensive drug. I get it. That's why I put in the algorithm. Lenalidomide is cheap here. Sagar and I have shown you get a 90% reduction in end organ damage with lenalidomide. In the US, it's 17,000, so people don't want to give it. Here, you have nothing to lose as long as you're able to follow them.
Thank you.
Thank you, Joseph. Vincent, can I ask a related question over here? So, like, can we use a little more potent anti-myeloma drug, say, for example, bortezomib rather than len? Of course, I know that there are no trials. Do you expect that this will have, in the same setting, more benefit than len? Maybe as not as much as DARA, or maybe as much as DARA also? Like, just a theoretical question.
Yeah, it's possible. And many people have asked me, how do I interpret Aquila trial? I don't think Aquila trial is about DARA. Aquila trial and other trials that we've done is about whether early intervention can delay progression or prolong life. Whichever drug you use is separate. With bortezomib, it's hard to recommend that when there is like really no trial data. So there is a trial right there for you. If you want to really do another trial here in smoldering, you could randomize patients to len versus bortezomib and see whether there is a difference.
So I think maybe just 2 more questions. Like, out of the 3 people who are standing, the first 2 who opted for questions. You go ahead, please.
Thank you. This was, I strongly believe, and I think you also echo the same point, in real world practice, clinical trials actually contribute to treating far too many, less patients, I would say. So with the evidence which you have shown, when a patient of a high-risk smoldering myeloma who fits into a treatment algorithm, walks into your clinic, how do you discuss out the evidence of limited DARA or len versus enrolling into a clinical trial? So how do you discuss it out with the patients? Okay. So in a real world practice, what do you do more often? Do you give limited therapy or enroll them in trial?
So this is a great question. And I think, you know, as you saw in my algorithm, either you treat them on a clinical trial or you give them treatment for early intervention for high risk. That's been my philosophy for many years. Actually, that same algorithm I've had for many years. Now we put it in up-to-date as well. And we have had a default view at Mayo and elsewhere that clinical trials are best. Do not follow my algorithms. If you have a trial, enroll in a trial. Better to enroll in a trial than follow my algorithms. If you don't have a trial, rather than telling the patient you will be fine and dismissing them and then forgetting about them because they're only on observation, they're not coming from treatment, you will be better off giving them DARA single agent or len.
So, would you like to defer to the lady? We'll permit only 1 more question. Your call. You can talk to Vincent afterwards, right? Thank you.
So just last question.
Yep.
Why was it preferred that DARA to be continued for 3 years and lenalidomide for only 2 years?
No, they are 2 separate trials. They were both done in different continents at different time points. Okay, one was the industry trial where they chose 3 years of treatment and stop. The ECOG trial actually didn't have a duration. it was indefinite till progression versus observation. What we found in the lenalidomide trial was most people couldn't take it for more than 2 years. So when we wrote the recommendation, we just said 2 years of len.
It's a dosage of lenalidomide when you're using it.
In the trial, I think we talked about this morning, even for full-blown myeloma in India, they cannot tolerate more than 10-15 milligrams, so that's what I would do.
Thank you.
Okay, thank you so much, Dr. Rajkumar.
Okay,
Much as we would like these discussions to go on, may I invite our next speaker, Dr. Samir Melinkiri. He will be speaking on the risk stratification of multiple myeloma.
I would like to inform the chair that we are really running behind time, so I'm not sure how many questions we'll be able to take.
So I think this is a rare opportunity for us. The temptation is too much, but I get your point.
Anyway, okay, so risk stratification of multiple myeloma, I'll try to go fast. So this is the importance of risk stratification, identifies high-risk patients for tailored treatment approaches, aids in predicting disease prognosis and survival outcomes, facilitates patient counseling in clinical trial design, and it should, any stratification should incorporate genetic, clinical, and biochemical factors. So these are the risk stratification systems that we're going to talk about. The ISS, the cytogenetic risk factors, the RISS, the R2ISS, and of course clinical behavior of the disease is not in any risk stratification, but we know that patients with plasma cell leukemia and extramedullary disease generally have an aggressive behavior, so that's a different way of calling them high risk. The emerging biomarkers are gene expression profiling, MRD assessment, and NGS. Now, although this is out, right from the time we were students, we've been memorizing this Dury-Salmon staging. So I'm just for nostalgia's sake and for the, just to see how it has evolved, I'm just putting this up. This was in 1975, and it went on for 3 decades. This staging was still there. So this was based on the hemoglobin levels, the calcium levels, a normal bone X-ray, and the quantification of the M protein. But somehow, the creatinine or the renal failure component never came in this. I'm not sure how. Anyways, so the international staging system came in 2005, and it's an alarmingly simple, staging system for a complex disease like myeloma. So stage 1 is beta-2M less than 3.5, and albumin more than 3.5, and stage 3 is beta-2M more than 5.5. Very simple. So the components of the ISS are based on these 2 laboratory parameters, the beta-2M, which reflects the tumor burden and the renal function, and the albumin, which reflects the nutritional and inflammatory status. Essentially, both of them will kind of focus on the tumor burden, the bulk of the myeloma that is there. But we know that you can have a myeloma which is not very bulky but resistant to treatment, and therefore the ISS itself was inadequate. So then came the RISS, which was introduced exactly 1 decade later in 2015 as an update to the original ISS. And this essentially combines the ISS with chromosomal abnormalities and LDH levels, which is LDH elevation is a marker of aggressive disease. So this is also combined. But the high-risk cytogenetics that was included in the RISS were only 17P, the 414, and the 1416. So RISS does improve prognostic accuracy. So I'll talk a little bit about the chromosomal aberrations that happen in multiple myeloma. So in normal plasma cells, you initially have these primary cytogenetic abnormalities, which are essentially IGH translocations and hyperdiploidy. And then when the plasma cells convert into an MGA stage or the SMM stage, then subsequently you're going to have secondary cytogenetic abnormalities. And of course, there are tens and hundreds of mutations which make the genome of the myeloma cells unstable. And after a while, that is going to culminate into development of these abnormalities such as the 1Q gain or amplification, the 1P deletion, 17P deletion, and the MYC translocations. And then you're going to have a full-blown myeloma. Many times at relapse, you can detect these secondary genetic abnormalities, which may not be there initially. And they lead to the aggressive forms of the disease as well. So the primary chromosomal abnormalities are the initiating genomic events that lead to tumor development, and is detected in almost 90% of myeloma patients. They usually occur independently and are believed to represent 2 different oncogenic pathways, so either the hyperdiploidy or IGH translocation, and occasionally both. The numerical primary abnormalities are hyperdiploidy, which is a good prognosis, responds well to IMEDs, and the adverse ones, which are near tetraploidy, hypodiploidy, and near haploid. The IGH translocations, which happen at the 14q32 locus, are seen in up to 40 to 50% patients with myeloma. And basically, they result in the fusion of the IGH with a partner oncogene, and the affected oncogenes are thereby upregulated by the IGH enhancer elements, and that leads to selective growth advantage. So in short, I'll just describe each of these. So the translocation 11-14, about 20% of patients are going to have this. Leads to a standard risk myeloma, which often has a lymphoplasmacytic morphology, high CD20 expression, and often seen in the light chain or the rarer myeloma variants such as non-secretory often tend to have 11-14. Some cases display elevated BCL2 levels, which is why venetoclax can work in some of these patients. And they are occasionally seen in primary plasma cell leukemia and extramedullary disease, but even these patients tend to have a better overall survival. The 414 is seen in about 15% of patients associated with a high risk, but importantly, there is improved survival of these patients with the addition of proteasome inhibitors. So they require PI-based induction, early ASCT, and PI maintenance, which is why yesterday in Biju's, the case that Biju was discussing in the panel discussion, wherein the patient ultimately received the CAR T cell therapy. That patient, at the first relapse, he actually never received carfilzomib. He received Darapom, Dex, and for those of you yesterday, and DCEP, etc. But the carfilzomib was missing, and I thought that should have probably been added. Anyways, so then the translocation 14-16, very small number of patients, but overall poor overall survival, often because of its co-occurrence with other high-risk abnormalities. There is the T16, 614, again very small number of patients. It has similar behavior to the 11-14 and has standard risk. And the 14-20 is the least common, but has very adverse prognosis. The secondary chromosomal abnormalities include the copy number alterations and translocations. They arise during the natural course of the disease. They increase the genetic diversity within the neoplastic populations and give a fitness advantage for tumor progression. And they're more often detected at relapse than initially. But although they can also be seen at the MGUS and the SMM stage in some patients. So the 1q21 gain or amplification, gain is 3 copies of 1q21 and amplification is 4 or more copies of the 1q21 region. It's a common abnormality seen up to 40% patients, and at relapse almost 80% patients will have them. And the more the number of 1q gains, you have this dosage effect of certain potential driver oncogenes within the 1q21 amplicon, and therefore you tend to have a worse prognosis with the more number of 1q21 gains that you have. And when the 1q gain, prognosis of isolated 1q gain was initially a matter of debate, but now it's kind of been proven that it is also significant for adverse prognosis. And the combination of 17p with 1q gain is called double hit, and a combination of double hit with an additional high-risk translocation is called as the triple hit myeloma. 1p deletion, 30% of myeloma patients, 70% of plasma cell leukemia patients, poorer outcomes but not yet included in the risk stratifications, and they have a worse outcomes when combined with other high-risk abnormalities. 17p, 10% of patients tends to occur later than the 1q gain, has resistant disease as we know, rapid progression, and the number of cells that actually should be called as significant when you have, to call it as 17p deletion has been variable. I think Mayo Clinic considers 20%, but in general 10 to 55% is bad. Anything more than 55% is really bad, and biallelic deletions are very poor prognosis. Now, the trisomies have good prognosis, median OS of 10 years, and interestingly, they negate the adverse effects of high-risk IGH translocations, including 17p deletion. So in this study here, you can see on the, in A and B. In A, this is patients who have no high-risk translocation versus those who had a high-risk translocation. But if you look at those patients who had a high-risk translocation with trisomy, then the negative effect actually disappears. And similarly with P53, this is without P53, this is with P53. But when you have P53 with a trisomy, it actually negates the effect of that. And then came the R2 ISS in 2022. The limitations of the RISS were that 62% of patients fall in this intermediate risk. Some lesser high risk and lesser lower risk. Most of them follow the intermediate risk, and these patients actually don't do similarly. So therefore, there's a need to reclassify these patients. So high risk disease 17P, 414 and 1416, but 1Q gain or amplification was not considered in the RISS, and double and triple hit were not addressed. So in the R2 ISS combines ISS, karyotyping, and LDH, along with additional high-risk abnormalities, that is the 1Q gain and extramedullary disease, and other potentially evolving biomarkers. So RISS is widely used in clinical practice, but R2-ISS is gaining adoption. R2-ISS was the European Myeloma Network. There was a Harmony project in which they collected data from a large cohort of more than 10,000 patients enrolled in 16 clinical trials. And then the additive scoring system based on the top features predicting the PSFS and OS was seen. And a good number of patients actually had high-risk disease. So I won't skip. I'll skip this. And so the RS, so you have the ISS 2 stage was given 1 score value. ISS 3 was given 1.5 score value. Diligence 17P, LDH, and 414 were given 1 score value each, and 1Q gain was given 0.5. And based on these, you could divide them as low, intermediate. That's RISS 2, 3, and 4. And these were the scores. Pretty simple. And if you looked at, so you can see that both the OS and the PFS, clear separation of the curves between RISS 1, 2, 3, and 4. Importantly, the breakup of the RISS stage 2 patients, the 62% who were intermediate, and you couldn't classify them further. If you superimpose these RISS 2 patients and convert them into R2 ISS, you will see that the median OSS was 89 months in the RISS and the R2 ISS 2, 56 months in 3, and 27 months in the R2 ISS 4 patients. So thereby clearly saying that these differences were significant, and confirms that the RISS 2 patients represent a heterogeneous population in terms of survival, and they could be discriminated with the R2 ISS. Then comes the gene expression profile based stratification. Initially there was a 70 gene model, then an 80 gene model, and the 92 gene signature. And high risk patients exhibit increased proliferation resistant to therapy. It's been there for a while, but not widely used because of lack of availability of this this test. Then incorporation of MRD may further aid in stratifying risk. So by next generation flow, NGS, multi-TOF or LCMS-MS based paraprotein identification and PET-CT, these are going to can get incorporated and further tell you how to stratify them during treatment. And NGS-based risk stratification can identify high-risk mutations in not just TP53 but a variety of other proteins, genes. And then identifying high-risk translocation, the ploidy status by NGS could be done, just like you have for AML or ALL now. Identification of subclone heterogeneity at diagnosis and tracking subclonal dynamics during treatment, and combinations of NGS with gene expression profiling, imaging, and MRD detection. So with this, I'm going to end, but I'm just going to make a statement on behalf of us community hematologists to the James Bonds of myeloma sitting in the front rows. We are already grappling with, we've just about understood the risk stratification of AML. That of ALL is still evolving. And lymphoma, even the WHO classification, I'm not able to understand. And now, I hope you give us some time, take it as a joke, but I just hope you give us some time before you have an NGS-based risk stratification for myeloma. It's really going to confuse us. So, yes, thank you.
Thank you so much, sir. It was a very enriching, as well as your closing comments were really, it gives us the actual idea of the situation for everyone. For lack of time, we will not take any more questions at the moment, please. And before I hand over the mic to the organizers for the next session, I would just like to thank the organizers for organizing such an excellent academic feast. Thank you.
Thank you to all the speakers for excellent talks. We close the session. And apologies for the delay.
Thank you so much. Thanks a lot. May I request Dr. Hari Menon to please conduct the panel discussion. Small announcement for all departures which are today and tomorrow. Kindly update your departure site, be it the hotel or the venue, at the travel desk outside the auditorium. It will facilitate a smooth and seamless departure.
So after that, this fantastic 4 speaker sessions, the panel discussion becomes more of exercise to understand what we do over here in India as far as the precursor disease management is concerned. There's a lot of clarity that we have had from the 4 speakers prior to this panel discussion. So I would, without much ado, and we're running short of time, let me call upon my esteemed panelists, Dr. Ajay Gogia, Dr. Anil Handu, Dr. Ashish Dikshit, Dr. Tufan, and Dr. Krishna Kumar. All of them are different parts of India, so we get a flavor of what they do and how they practice in this particular entity. So, since we are running short of time, I would just Dr. Shaurya Ghosh to, yes, you're there. Thank you, Shaurya. Yeah, okay. So, Dr. Anil could not join us today. So, I just thought I'd just have a prelude to this kind of thing, the precursor disease states of plasma cell dyscrasia. We mainly looking at the monoclonal gammopathy of undetermined significance and the smoldering myeloma. And what is the relevance as far as this is concerned is the percentage of affected individuals with each of the precursor disease will progress to a myeloma. And the challenges, of course, over here, as we have seen in the previous discussion, and it is much more exaggerated actually in India, is the difficulty in predicting which patient will progress, and it's not obvious which patient should be treated. But I think there's a lot of clarity as far as smoldering myeloma is concerned after the discussion today. And as Dr. Munshi had already alluded to, the immune changes are quite profound, the genomic changes are quite profound, which adds to the progression of the MGUS to smoldering myeloma to myeloma. And you have genomic changes in the form of translocations, hyperdiploidy, which are primary events, and then you have secondary changes, the copy number alterations, DNA hypomethylation, and also you have immune changes, that is the immune resistance to immune exhaustion, which Dr. Munshi beautifully alluded to, and also the immune suppression, which actually dictates who are better controlled and who progress and who benefit from treatment. So with that background, and we don't have too much data. Ritu from All Institute of Medical Sciences and my teacher, Dr. Lalit, their paper was one of the ones to look into in a hospital-based registry on close to around 4,000 patients about the prevalence of MGUS, and this was about. It is far more as the age advanced, as is true in many of the studies that we have come across, and it ranges anywhere between 0.83 to 1.75. And yesterday we heard Uday speak about the prevalence of MGUS in the rural population, and it is to about 1.6 to 1.79, and it increases with the age of the patient. So with that in mind, I just get to the precursor state. So I just go from backwards. So what are the implications for identifying these precursor health states in India presently? Is it very important for us to get into this? Yes. Yeah.
I think the majority of the Indian patient, if you consider the clinical perspective, the majority of the physicians, they have a mild glomerular raise, and they did the serum protein electrophoresis, and they sent it to the our hematologist or oncologist. But usually in Indian setting, by continuous monitoring of this, the MGUS and the smoldering in the first country, I think it will be very difficult. But yes, in the high risk group of the population, we can focus that the continuous monitoring is very, very important. But the currently in India is basically based on the referral systems in the patients have a globulin raise, and they did the serum protein electrophoresis. If the small amount of band is there, then they send to us.
Yeah, so that's the profile of disease. So do you think that majority are actually manifest diseases that we get, and we don't have a system in place where we are getting those proportion of patients who are actually the precursor
I think it is absolutely right. In India, currently the majority of the cases, it is symptomatic-based treatment is there. The majority of the patients, they are the symptoms. They came to the physicians, then we treat the patient. But few number of the patients, they have a smoldering also, that the embed is high and there is no crab is there. That group of the patient we also seeing in our clinical practice. So I think the routine screening and the routine healthcare facility driven MGAS and the smoldering, I think it is seriously lacking in India.
Ajay, your...
So the implication for the healthcare in India, but most of the time MGAS is incidental finding. So is only 90% of the MGAS is incidental.
Could you just hold your mic? Yeah.
MGAS is an incidental finding. There is no patient present with the MGAS in the OPD. So there is no much as such healthcare implication related to for the diagnosis of MGAS. Definitely MGAS has to be routinely followed to see is the transformation to SMM or not.
So it's almost like an exception for us to get an MGAS patient. Yeah, Ashish, yes? Yeah.
So it depends. A lot of labs have started doing health checks, and the health check, when they are doing LFTs, they are routinely giving electrophoresis as a part of it.
And so the fact that they highlight everything gets the patient to start seeking an opinion on that.
Yes, so we have started seeing more and more of MGAS cases because of that. I think that will provide us some population data also, because a lot of people are going, even though that will be a bit biased also for the patients who are going for a health check only. But it's not from our hospital, it's going across different hospitals. So I think it is going to increase. We'll pick up more and more of these pictures.
So do you think there is also a bias that we get those mainly from the nephrology department many of the time?
There are two departments. One is the nephrology, the other one is neurology.
Neurology, yes. Yeah.
Because this is a routine part of their workup, and I think their protocol has the algorithm of doing an FLC once they find a small fiber neuropathy. So there are two ways in which we can look at this system. We know that the data says that in India, I think you just put it up now, we have a lot of patients who are coming at a much younger age. So, are we looking at screening a little more aggressively to catch these patients before they become, as a clone you catch them earlier before the end organ damage comes in. So, it is imperative, just as Dr. Rajkumar just mentioned, that the cost of treatment in India is quite okay and for people, and it's acceptable. So that is a big plus. But at the same time, I think we will be left with a huge set of patients without any end organ damage that's related to our disease, probably due to some other multifactorial cause. And I think they need the proper risk stratification. And as of now, if it is going to be a SMM, we follow the 2022 rule, which is much easier to follow. And otherwise, we just have to keep these people under follow-up.
I just wanted to add one thing. There are two contrasts. On one hand, we see younger myeloma patients as compared to the West. On the other hand, yesterday evening, Dr. Uday showed a wonderful presentation. Showed his data of over 1 lakh normal people who were screened. And the rate of MGAS was much less as compared to the Western data. So there is a paradox.
So it was sort of...
It was in the 1%, lesser as compared to the West, but we see younger patients. So maybe better, and we have heterogeneity within the country.
Right.
So that is data from one area of the country. When we have more data, maybe we'll be able to have guidelines for population screening.
So you would say that we need to generate more data before we can take action on all these things.
With more cohorts.
So this was just the paper from Pankaj and from the PGI group, which actually there are some concerns that probably it's a decade earlier in our presentation for these patients, and probably the cytogenetic, some of them harbor a higher risk cytogenetic group. So the possibility of these patients progressing to a myeloma and preventing the end organ damage, as Dr. Vincent had mentioned, may be a good idea in these patients. So I just have put up 3 case studies. One I'll just tell you verbally. The first one is, this is a 68-year-old male who has been identified to have a little bit of high protein in 2014, but he eventually came to me in 2017. And at that time, the immunofixation had shown an IgG kappa type, and the concentration was around 250 milligrams, and also the free light chain ratio was 0.8, and you had the serum creatinine was normal, and the bone marrow evaluation at that time had less than 5% plasma cells, but we did not do a flow characterization on that. He had come to me after that, and the PET scan also, he had got it done and it was normal. So and the second case and the follow-up, and he has been on follow-up since then, and I met him a month ago, and he continues to be in the same plane and then this is a 65-year-old lady who came to me in June, referred from the nephrology unit because she was been a diabetic for 20 years on insulin therapy, and there was a progression in the creatinine value, for which they landed up with the nephrology unit, and the nephrology unit conducted the free light chain, the free light chains and also serum electrophoresis and immunofixation. There was a small monoclonal band, which was IgA lambda actually, and the free light chains were within normal limits. And then she came to me in June when I had suggested that the possibility of doing a biopsy to rule out an MGRS or renal involvement by so she eventually got it done after going through to multiple doctors from the nephro unit again in December, and that showed a mesangial proliferation, basement membrane thickening, and strangely on immunofluorescence, IgM patchy deposits. And the report was mainly this is diabetic nephropathy and not so much of any deposition disease. And the bone marrow studies reveal no plasmacytosis. So 24-hour urine protein was 24, and the third patient is something like a smoldering myeloma whom actually the patient was seen at Emory and he was visiting India, and he had a history of being diagnosed with herpes simplex, oral herpes simplex almost a decade ago, and then he had this monoclonal bands which were detected in 2017, which were not high, and he was on serial follow-up over there. And one bone marrow was done sometime in 2023, which revealed clonal plasmacytosis of about 63% actually, and he had 11-14 translocation, but his biochemical parameters are normal, his renal functions were normal, and he did not have any symptoms at all at this point of time. And he was, based on the fact that, based on criteria and clonal plasma cells of 60%, he was advised to enroll into a clinical trial, which he refused, and he's on follow-up still not going on. So these are the 3 case scenarios. So what are the, how do we categorize these patients based on what do you follow in your clinical practice in terms of categorizing these patients?
Yeah, I think your first one is the MGUS is there, and the second one is basically the DICE, because the immunofixation is Ig lambda, and also the immunofluorescence, so the IgM deposit. And there will be the mild proteinuria is there. That can be called, we need to follow up the patient, whether the patient has been developing the MGRS. And the third thing is that there is a plasma cell is more than 60%, the 63, it will be directly called the multiple myeloma based on the current
and
definitions.
He had an IgG kappa.
Yes. So I think the 3 category of the patient we are clearly seen out into clinical practice. The first one, I think, the first one is completely you need to follow up, and the second one, yes, we need to follow up particularly the protein level, and the proteinuria is become very, very important, and the raising of the creatine. Then only we can intervene. And the last one, I think they need some intervention.
Ashish or Krishna?
I just had one question related to that. How many of us amongst the panel are doing routine bone marrows in AMGUS
Yeah, so that was one of the questions that was coming up as part of the investigation. So you can answer that question
So
then.
I don't do it.
You
So
don't
I'll
do bone
clarify,
marrow.
I don't do it unless there is any other.
But then if you don't do a bone marrow when a patient comes or when you suspect an MGUS, then how are we able to categorize that? Yeah.
Yes. So I don't do it as a part of my practice. That's why I'm putting it forward. Because if they are doing fine, if there are no other problem, main thing is mainly to predict whether they are in SMM or no. And if I'm going by 20 criteria and they are remaining 2 are within the bracket, I usually don't try to do it. So that's my approach on it, but I just wanted to take note.
So I think the first case is an MGUS.
Yes.
So I think we are not looking at already an established myeloma, which is smoldering or symptomatic. So I think practically in the Indian practice context, I think accepting a bone marrow, which probably the patient calls it invasive, I think the follow-up of patients in our clinical practice sometimes becomes challenging. So if we have a patient who comes in with all features of MGUS and non-invasive, in fact the criteria say you don't even need to do a low-dose CT, or you don't need a PET scan, you don't need a bone marrow if they have the clinical criteria, the Mayo criteria, which is low risk. So I think you just put up a very typical patient with a low-risk Mayo criteria. But said that, I think when the patient has been specifically referred to us to rule out myeloma, I think imaging definitely yes. And for various reasons due to low-dose CT protocols and waiting time, we do a PET, which is a lot easier. And if the PET is negative, bone marrow is offered to the patient and documented. And if the patient says he wants everything to be ruled out, we do a bone marrow. Although I think it's not the recommendation of the criteria, but I think in clinical practice, I do everything in first shot.
So Ajay, would you agree that, if you don't do a bone marrow, how are we going to categorize it?
So I don't know. The MGUS has to be characterized after all the modality.
Yes,
it has to be bone marrow, has to be low dose scans. That's why you diagnose MGUS, because all the criteria in Mayo Clinic, you have to do 3 serum M protein, plasma cell, and minus CRAB. So you define CRAB, you have to do for bone lesion, you have to do scans.
Yes.
So that's why you categorize this.
So we can't get away with this thing if you want to be, and we want to stick to identifying what we are dealing with, isn't it? Yeah.
So definitely scans or marrow has to be done to qualify it is true MGUS.
Shaurya.
Yeah, I would second that thought. So if somebody is referring a patient to us with a suspicion of a plasma cell dyscrasia, we need to see what kind of a plasma cell dyscrasia it is. So we do a bone marrow. We first see the biochemical parameters. We also see the urine. We try to look for the clonality using non-invasive tests like the serum and the urine. If there is any hint of a clonal process going on, we do go for a bone marrow and imaging, and then stratify whether it's SMM or MGUS or myeloma.
So, Tufan.
I think we can look in the other aspects also, because if the patient has only the small embed is there, and if you go to the criteria for the 22 and the 20,
that's
there is a slow smoldering group of the patients.
Smoldering, yeah.
So we are doing nothing for the patients. So my perspective is that by doing the unnecessary, the invasive procedure and the whole body PET CT, I think it will be not judicious. But yes, if your embed is quite high, if it is the 1.5 and the 2, yes, you can jump to all the investigation and try to prove it whether it is dealing with the case of the high-risk smoldering or it is the myeloma, the plasma cell will be more than 60%.
So I don't think we can have a consensus over here, but the thing is that by definition, if you go, you need to do those. But otherwise, I agree with you. Many patients would not be, and we have to discuss the implications of the bone marrow findings. If it comes out positive, what we need to do. So these were some of the tests that, I've just put it up. We have already discussed those tests. Shaurya, you have anything to say? Okay. So I just go to the next, and risk stratification and progression of this. So what is it in the clinical practice? What is the usual risk stratification? Is the Mayo Clinic model or the revised RISS system? Anybody can take that. Yeah, Shaurya.
We go ahead with the Mayo risk model.
Okay.
For the stratification.
Okay. Any other? No, and these are, so on a bedside, this becomes easy for us to actually look into the low risk and intermediate risk and high risk profile. And also, if you're really thinking of a smoldering myeloma, then the 20 model is also useful. How do you assess for predictors for transformation? I know there are so many tests that we can actually resort to, but do we ever look at that beyond what we have as a basic assessment?
Serum FLC might be add on this.
Yeah. The involved free light chains, yes.
So other than that, I usually do a scan after a year, means for at least first 2 years minimum, and then subsequently depending on the age of the patient. If it's a very young, then we'll not do as often. We may give a skip year and then do it. But for an elderly, I will still prefer to do a whole body low dose CT because that works out very well for us.
Yes.
So that is what usually we do. Other than that, usually the same criteria, low dose, no symptoms, everything all right, we'll just observe.
Okay. So, so then comes to my next question. How do we follow up these patients? I mean, once you have established the diagnosis of MGUS or a smoldering myeloma, how do we follow up those patients? Yeah.
Follow up with the low risk is yearly follow up with the same serum FLC, M spike, and definitely urine 24-hour protein. Because
so does the frequency change for if you have suspected a smoldering vis-a-vis
there's no
MGUS?
such guideline, but in MGUS we usually follow in our institute is low risk is yearly, if high risk is 6 monthly.
Yeah.
And urine 24 urine is mandatory because most of the time we directly go to amyloidosis.
Yes. Yeah. Okay. Yeah. Sure.
So pretty much that, and for high risk, it's little slightly more closer follow-up, 3 to 6 monthly.
And Krishna, what would you think as when you consider for an early intervention in these patients? When would you take it as a point as an early intervention?
So I think
based on the follow-up findings, yeah.
Clinical and the lab, basically the lab biomarkers. If there's going to be a brisk rise or a tilting of a ratio that's going up, in case of smoldering myeloma, and I think that's where we tend to get a bit aggressive. And when it is a small, I have a couple of MGUS in follow-up. I think to reconfirm that it is MGUS, I initially call them in a little early, maybe about 6 months.
So does time
one or two visits.
Does time frames matter over there? I mean, as we in the graph which we're showing, yeah. So
in MGUS, yes, we know that it is a consistent curve that keeps it's a cumulative risk over lifetime. And in smoldering myeloma, suppose they hit a 5-year. Although I just have 1 or 2 in that category, then probably we reassure, but still the follow-up and all that goes once in 3 months. So we don't go lesser than that.
I think that apart from the investigation, the 2 to 3 things has to be followed carefully. What is the hemoglobin level? So along with the serum protein electrophoresis and the FLC ratio, if the hemoglobin is, though it is the normal, but if it is gradually fallen down, and another in terms of the creatine, if the creatine is going up, so this continuous monitoring of the creatinine and the hemoglobin will guide us for the early intervention. Okay. But currently the smoldering, the low and the intermediate, we are not treating. The high risk, yes, we have to treat it. But even in the high risk group of the smoldering group of the patients, you can treat aggressively if their hemoglobin is going down and also the creatine level is going up. I think these are the 2 clinical parameters we can use until the clinical practice.
all right. So with the emerging the therapies that we have just discussed shortly, and also which has been in existence for quite some time, are you, I mean, with the group B biased towards just going ahead and treating smoldering myeloma because of the efforts that are required for patients follow-ups? I mean, when you know that there is a higher risk for them, would you think about treating smoldering myelomas as full-blown myeloma itself, or you would still resort to the guidelines to follow them up, ascertaining what risk group it is, and then, yeah. So Ashish, yeah.
So I think till the time this daratumumab data came, I was still looking at that in case there is a high risk smoldering myeloma, if I want to decide and treat, I'll go all out.
So why didn't you choose lenalidomide? It has come quite a while ago. Yeah.
So the only reason is because I wanted to see the long-term data related to that. What if these cases become more resistant when they grow? The same thing that we are seeing with all the other myelomas, that once we once we start with the first treatment, whenever the relapse happens, they are more aggressive. Then the survival comes down. So the concern is, did we miss on that timeline there at that point of time when we could have done a transplant also at that point? Now I think DARA exposure related, that data seems very interesting because we are not compromising marrow as much. At the same time, we can always decide whether duration is that much required or no. But that seems interesting. Lenalidomide, obviously, it is very, very tempting. I would rather say high-risk myelomas, I would rather be very keen. But I'll be a bit nervous to use lenalidomide alone.
Okay.
So if I have to use...
So your worry is whether you might induce the thing. But the data has clearly demonstrated that it prevents end organ. There's a delay in end organ damage. So, and it's quite a mature data over there. Ajay, yeah, and Shaurya after that, yeah.
So high risk, definitely no observation in this. Only current practices, only single agent lenalidomide for 2 years is sufficient. But for the DARA data is again, we look through all the original article with in between the lines. All the DARA on the patient progressed on the DARA. Only 20% received DARA when the multiple myeloma was progressed. So we don't know the impact of DARA in SMM or in multiple myeloma. We have to look carefully in PFS2. So,
for high risk, Len has good data, Len or Lendex. Only concern is, do people face difficulties in mobilization later on for a transplant? If somebody is giving Lendex, let's say indefinitely.
But we give otherwise also indefinitely Len, and we just wait for four weeks if you're planning a transplant and do a transplant. I dare say that's really not a.
So giving for 2 years is not a.
It will not be a concern. We have.
Another thing is that in terms of giving the Len only, we are able to prevent the 90% of the patient for the progression. So the 90% patient will not progress to the end organ damage.
Yes. Yeah.
So there is only 10% of the patient we are losing from the stem cell transplant, and we are worried about that. Yeah. I think we will look for the 90% of the patient rather than the 10% of the patient. In terms of the DARA also, yes, there is the 10 to 15% risk of the progression is there. We can do the transplant later on. But in the Indian, the financial condition, I think the Len will be the wisely chosen, one of the important in terms of the smoldering myeloma.
So let me turn it around a little bit to say that, okay, you decide that this is a smoldering myeloma, but now with the data that has come up, would you be more discerning about categorizing this into a high risk and choose those high risks and do all the tests that are required to prove or disprove that this is a high risk before embarking? Yeah. So, yeah, Ajay, you can.
So
your thoughts on that.
If we have to treat a high risk, if we have to treat smoldering, we have to categorize and see whether it's high risk or not.
So at least that should be looked at, sir, because we don't want to unnecessarily treat as Vincent has beautifully demonstrated in his talk. Yeah, Ajay.
High risk population is only 30% with the 14 partner and 17 Q. So high risk 30% has to be treated, I said, single agent Len for 2 years.
Okay. So I just this is more of a question in terms of the diagnosing and telling the patient that he or she has a pre-malignant condition. So have you experienced in your thing about the anxiety that it creates in patients, and how do we deal with that kind of thing? And yeah, so.
I think it's a very, very important aspect to a PARC stat in terms of the anxiety. So if the patient has a MGUS, you are doing a lot of the investigation, the patient will be the more worried about that. So this is a very, very important concern in the Indian context also. But yes, we have to also think for this by the single time screening and subsequently follow up. This is also very, very important. And also the add up the anxiety of the patients. So from the pre-malignant to the malignant condition, I think we are adding a lot of the anxiety of the patient. So it should be judicious. that the which group of the patient you should do the extensive investigation to prove it that patient has really going to develop the malignancy.
Any other views?
It depends on like how we explain the prognosis of MBL patient, monoclonal B lymphocytosis, how the prognosis we explain the low-grade lymphoma in early stage or stage 4. If we tell the figure accurately and what the implication, this might be, you can avoid all the anxiety and all.
Yeah, I totally agree. It's just about it. If you learn the art of counseling an indolent lymphoma and tell them you have cancer but you don't need treatment.
But that's a very big challenge, actually.
It's a big challenge,
Yeah,
and
but
the answer to this question depends on where you're practicing.
yes.
And who is your patient population. If you have a patient population educated enough to download ChatGPT and sit in front of you, and then they want to make near real sure that there is nothing, probably you may be coaxed to evaluate them a little more and then tell them you don't have anything. But if you see an M component and you tell them, yes, the guidelines and my gut feeling tells me you're not going to get anything, so you come back and see me after 6 months, they are going to be actually in more anxiety. So it all depends on the patient population and where you're practicing. If it's resource constrained and the patient believes each and every word that you utter, then I think you can take the conservative approach. But if there is a patient who is a little hard to crack patient,
Sure.
I think you have to evaluate them fully.
Thank you. Are there any more thoughts, and is there any other any comment from the audience or any question? No? Yes, so then we are on time, and I really thank a rather difficult topic to actually discuss, because this is in its it's not something that is addressed always in our day. We always treat myeloma patients, and it's probably good for us to generate data and also look at how we need to look at it, because we don't even know what is the prevalence of all these in our country. So it'll be good to do something in terms of trying to come together and generate data on this, and then look at trying to form a consensus guidelines, and probably Image can be a platform to do something like that. And thank you so much, my esteemed panelists, for contributing to this talk, and I thank the organizers for the opportunity. Thank you.
Thank you, Dr. Hari, and the panelists. Having fed your minds well, it's time to nourish your bodies. On the ground floor, the lunch would be served at the same venue under the tree. We would see you back 10 minutes past 1. Thank you so much. And I'm reminded of a very famous son of Bengal who once said, "You can't cross the sea by standing and staring at the water." And it's my great privilege to introduce and welcome the Indian stalwarts who have been leaders in their own right to chair this keynote address. May I have the pleasure to invite retired Lieutenant General Dr. Velu Nair, and Dr. Tapan Sekia, one of the pioneers of bone marrow transplant, up on the stage to chair the keynote address and introduce the speaker.
Hello, check. I think the culinaries, tastes are so good that I still find half of them to actually come in. So, but in the interest of time, they can keep joining in until my friend Dr. Tapan joins us. So I have the pleasure to actually introduce my friend, and he actually doesn't need any introduction in India or abroad. But having said that, traditionally we always do this, and this is the keynote which we've been waiting for. He's going to talk on a journey in myeloma and academic medicine, and he's going to capture and have a thrust on redefining multiple myeloma with a curative aspiration. Okay, so Professor Nikhil Munshi works in the prestigious Harvard Medical School in Boston, and he is actually wearing multiple hats. He's not only a professor, he's the family chair and director of the basic and the correlative science, and the associate director of the Jerome Lipper Myeloma Center at the Dana-Farber. He has been working in genomics of cancer and myeloma for a long time. And his main aim has been to work on genomic instability and the mechanism which drive it to improve diagnosis, prognosis, and therapeutics. Importantly, he also chairs the immunoeffector cell therapy I would say department with the vaccine approaches and the famous CAR T cells. And he was the one who actually led the leading papers published in Imagium, which are landmark milestones. He has received multiple awards, including the Lifetime Award from the Waldenstorms Award for work in myeloma, and the famous, prestigious B.C. Roy Award from the President of India. Dr. Nikhil Munshi, please.
Thank you, Dr. Nair. Thank you, Dr. Saikia. It's a real pleasure being here, and also right after lunch. So, so what I'm going to talk about more is how myeloma has changed over the years, and over the years that I have been involved in one way or another with myeloma. So I'll show a patient that I saw when I was a fellow. That's 38 years ago. So this is a 65-year-old gentleman who had IgG kappa multiple myeloma. At that time, Duri-Salmon staging was there, so it was Duri-Salmon 3A, significant bone disease, and patient got VMCP, VBAP combination. And those of you who know this combination would be considered in the older age group by definition, if you know what this is. So I don't think anybody's going to raise their hand if I ask who knows this. And minimal response to the patient, 6 months, got second-line VET treatment, and that's came to the clinic, and that's when I saw him with my supervisor or my attending. He'd come with progression, had increased bone disease, significant pain, myeloma had progressed. And the question was, what do we treat the patient with? And what I was told by my attending is that we are going to use hemibody radiation. And I don't know how many in this audience knows what hemibody radiation is, because I don't think it has been used in 40 years. And I don't think we did hemibody radiation on this patient, which I don't remember. The point was, that was the state of the art then, that as a second or third line, and it literally means, as the name means, you give radiation to the half of the body. So half of the pain will go, the rest of the half pain will remain, but it's total palliative treatment. So what did we not have 38 years ago? We had limited diagnostic capabilities, had limited just clinical prognostic thing, anemia, bone disease, kidney function, that's Duri-Salmon staging. We didn't understand the biology much, and therapeutics was limited to VMCP and VBAP. VED was a very brand new kid on the block with new thing. And then response criteria, you wouldn't believe, the complete remission was when there was a 75% decline in paraprotein, not even 100%. So we could have a lot of protein and still it's a CR. So from that time onwards, we have made a lot of progress. So I'm not going to tell all the progression in 38 years. I'll bring it to today. And look at all the 5 different things: diagnostic, prognosis, biology, and then therapeutics and response. So there are a lot of newer diagnostic methods being introduced. In 50s and 60s, we did SPEP, did bone marrow, and did plain X-rays. In intermediate 2005, started doing free light chain, FISH became available, and MRI with some research thing. Now we are beginning to have, and there was some discussion in this meeting, and as it has been in most of the myeloma meeting these days, that we are beginning to incorporate sensitive protein detection methodologies and improving our limited diagnostic capabilities. So mass spec-based protein assessment is not standard, it's not done routinely, but it's beginning to be evaluated for its value. So this is a large study, and I'll just go to the full slide. I didn't want the animation there. But the point is that in a large study performed by Dr. Murray, who was kind enough to provide this slide, they looked at patients for presence of a low level of protein, which is, so these are the patients who are negative immunofixation, they are negative by SPEP, and then mass spec was performed. And you could see that using the mass spec,
you can detect in these patients, almost 70% of the patient had presence of protein, while immunofixation was only positive in 30%. So 50% increase in sensitivity. And utilizing this method, now we are beginning to look at where can we use it. It's a proven technology to detect M spike, specifically tumor-related. There are many mass spec methods. I'm not going to go into details of those, from sequencing of protein and then looking at those peptides to using just small detect type of thing. In comparison to serum protein electrophoresis, it is better at detecting multiple bands. It can detect glycosylation of protein, which has some functional impact, improved specificity. We are beginning to evaluate its role in minimal residual disease assessment. Instead of doing bone marrow, can we do this? And we can detect early relapse. When nothing is detectable, you could look at that. Also in patients who might be otherwise non-secretory. So a lot of application that are over and above what we do today in the lab. There are challenges. It's not a panacea. It's not going to answer all the question. Being able to detect a very low level protein may be a problem. As we were talking earlier today, one of our colleagues had patient with tuberculosis with M spike, and when TB was treated, M spike went down. So we get lots of infection. We might end up seeing small bands using mass spec. So we have to understand what is there. Rheumatoid arthritis, you might see a band. Method may not be available. Standardization is needed. In Mayo Clinic is done with a wonderful methodology. Others may need to learn it. The cost may be a little bit important compared to immunofixation, and then who pays, etc. But all these problems apart, they're all solvable problems. A new technology is now being used instead of what I showed earlier on for the patients that I showed. So there are new diagnostic methods, and one of the examples is here. I'm not going to cover all the aspects, but just superficially. The next is prognostication. That particular patient I showed had Dury-Salmon 3A. That Dury-Salmon staging system is not being utilized anymore world over. Then we started doing karyotype, not being done anymore. Then came FISH, which is still standard yesterday. Today and tomorrow, we'll talk in a minute. And then transcriptomic analysis, DNA sequencing, and then more involved analysis by newer method. But DNA sequencing is beginning to become important. So we had this IMS, IMWG consensus for revisiting the risk stratification. What should be our current high-risk disease? So what you could call it consensus genomic staging. And this, the definition, the new definition that has been agreed upon by everyone, hopefully to be published within next few weeks, defines the high risk by this criteria. The deletion 17p with a 20% cutoff or TP53 mutation. The 14 related translocations by itself are not considered high risk anymore. So patient has 414 alone, that would not be called high risk. It has to be with either 1q gain and or 1p deletion. So both together. The third is 1p32 biallelic deletion or 1p32 deletion with 1q gain. That's high risk. And then finally, we still have high beta-2m 5.5 with normal renal function, not without it. So this constitutes the high-risk patient population. It constitutes around 23% of the patient in most of the study, between 22 and 25% of the patient. The recommendations are that we now need to shift to a sequencing-based methodology for detecting this. You cannot look at p53 mutation by FISH as clearly. Even 1p deletion, more cryptic deletions cannot be. So I think the recommendation is to begin to shift to that. If FISH, the sequencing is not available, then one may need to look at more purified cells for some of these changes while the shift is made from FISH methods to sequencing-based method. And reporting of percentage of cells with abnormality are going to be very important, and that's where the purity of samples will come into picture. We know that myeloma is heterogeneous. However, currently doing one bone marrow and finding what we find would be considered as standard. We cannot poke multiple times. And when do we do it? We do it at the diagnosis, we do it at the relapse, and if the protocol requires on a study, we would do it then. And so this is going to be our new definition moving forward for what would be called a high-risk myeloma, very different than the patient I showed 38 years ago. Then the third thing is biology, and that's where significant changes happen in last 35 years, 30 plus years. And it's mainly because now we are beginning to look at various components of the genome. RNA transcriptome was the first one to be looked at by various methodologies, now sequencing, of course. And then DNA is again looking at various aspects of it, including methylation, epigenome, etc. And so these are the two areas where significant advances happen. And the reason the advances happen is what is shown here. And I'm not going to go through detail, but these are all various sequencing methods from GLORY-seq to EM-seq to methyl-seq to etc. All are 6. But because of this technology, we are now able to understand that the disease better. I think you can see it more clearly here of all different these 6. And this slide is also, I think, a year and a half older. There are many more here that are not represented here. So what is important is that how do we use this method? And I'm going to show you one of the newer data about how this methodology can improve our understanding of the disease. So one of my colleagues, Dr. Samur, utilized this comprehensive analysis of DNA sequencing, but using a very simple-minded data. What he did was that looked at the hyperdiploid myeloma. There are 3 chromosomes. Obviously, 2 chromosomes became 3 by one of the chromosomes being duplicated. That's simple as that. Now, if you look at chromosome allele 1 and allele B, one of them is, before it is duplicated, there are multiple mutations. So the green mutations are the mutations on allele B, the purple are on allele A, and the purple on allele B. Now, one of them is duplicated. Let's say B is duplicated. Now, B will have the same purple dots. So the duplicated chromosome will have, when you sequence it, 66% of the mutations will be present, 33 won't be present. The non-duplicated chromosome will have 33. So by looking at what proportion of the sequences we'll see has the mutation, we can say whether they are allele A or B. How does it help us in a different way? It helps that if the mutations happened after the chromosome became 3, then it will be only 33%. So any mutation which is 66% happened before the hyperdiploidy happened. So now using this method, we can judge what mutation came before the hyperdiploidy, what mutation came after hyperdiploidy. So it's a very simple mathematical thing, but now you can tell what happens. So 66 VAF, that's hyperdiploidy before hyperdiploidy mutation, 33 are happening after. So using this, he came up with an analysis of a large number of myeloma patients. And what you find is that, and this can only be done with hyperdiploid chromosome right now, that's what this publication is, that there are 3 types of mutations. One is the pre, you can see here, there are 2,000 mutations happen before hyperdiploidy happens, and they are clonal. They are in every myeloma cells that we sequence at the end. Then there are similar number which are still post-hyperdiploid. They are still clonal. So the myeloma cells are still growing together. There may be just one small number of myeloma cells. And then there are many mutations, 3,000 plus, which are subclonal. When myeloma starts developing multiple clones, each with their own mutation. What is interesting in this analysis was that when you look at the type of mutation, there is a type called clock-like mutation, and I won't go into bore you with the technical detail, but that tells us that those clock-like mutations happen like a clock, that every year in somebody's life, 30 mutations happen, and that's described by many people, including us, how many mutations per year happens. So using that clock-like algorithm, the first blue dot is the estimation of when did the first hyperdiploidy happen by looking at the mutation. And the data shows, and what is here, is that the earliest time when the first chromosome became 3 is the age of 13. So in literally teenage years is when first hyperdiploidy happens. And within 10 years, the second figure on the right are all the chromosomes that becomes hyperdiploidy 3, 5, 7, 9, 11, 15, 19, and 21. That by the age of 30, 10 years after the first haploid, 20 to 12, between 25 and 30 years of age, all the chromosomes have become hyperdiploidy, which are going to become hyperdiploidy. So that's when in the body there is a cell which is probably going to destined to become at least MGUS, if not myeloma. And so what is interesting is this model that these mutations happened before. They're all in clonal mutation in every cell. There's only one cell at that time. Then there is a further growth. And the real myeloma, so this is where the red line, the beginning of red line is beginning of MGUS. And the end of the red line is when myeloma is diagnosed. So between age 30, at some point MGUS appears, and then the age of 60 or so was the average age in this data set, is when patient develop myeloma. So one thing, it's an interesting finding, how early changes start to happen. On the other hand, we need to keep in mind that how the disease might develop and what can we do at what stage. And the power of technology. Now there are 11,000 mutations in general in myeloma, and using this mutation, we can look at how these mutations are impacting the genome. So we can calculate what is called genome scar score. And to make it short, based on genome scar score, what Mehmet also did was to analyze, we all talk about high-risk disease, which is important. However, what's a good risk disease? Which patients are going to, we can say you're going to do fine. So he tried to define the really good risk disease, and using this low GSS score and a chromosome 9 gain, these are the patients who over a period of 7 years has 100% survival. And in a validation cohort, there was 90% overall survival. So we can begin to use this technology to identify high-risk patients. The next thing is, using this technology, we can look at what is the treatment do to the genome. And so this was a part of our analysis of the IFMD-FCI study, where we had 720 patients who were randomized. Transplant came out superior, of course, as predicted. And then we look at what does high-dose melphalan do to the myeloma genome. And the short of the long discussion is that there's a significant increase in mutations in myeloma cells when they relapse after transplant. So high-dose melphalan causes more mutation. And I can answer question, what does that mean? However, the important part is that the treatment leads to selection of cells and development of thing. And one of the good example was this single-cell sequencing data, that in this particular patient, at the time of diagnosis, there was no high-risk feature. However, at the time of post-induction relapse, patient came up with 1Q amplification, and at second relapse, it was almost clonal 1Q amplification. However, the single-cell sequencing showed that small number of cells were present even at diagnosis with 1Q gain, which FISH misses. It's not sensitive enough. That's another reason to do sequencing-based method. And this particular publication, I think last year or year before, showed that even this low-level detection of 1Q carries poor prognosis. So larger analysis confirms that. And so I think we need to look at sequencing-based method to find some of those lesser frequent mutation. Now in this same patient, so the analysis was this, that early presence of 1Q was still bad, doesn't have to be in high proportion of cells because it's going to get selected over time. However, interesting part in this patient was that when we looked at the single cell, there were 3 changes seen. Patient had 1Q loss, Anyway, I'll use this. So patient had 1Q loss, there's a circle. 1Q gain, 1P loss, 1Q gain, and 17P deletion. Interestingly, these are all high-risk features. However, these are single-cell sequencing, and what you see here is that these three high-risk features are in different cells. They're not in the same cell. So the complexity of the high-risk definition may be defined very differently as we use these newer technologies. And finally, we had publications earlier on that showed that post-BCMA CAR T cell, patient can lose BCMA by genomic changes. This is where there was a biallelic loss in one of our patients who relapsed and did not respond to a second CAR T infusion. And this patient had loss. The clone existed before at a very small level. It expanded post-CAR T, initial CAR T cell and initial response on the left side. So treatment effect needs to be and can be studied. So that's short spiel on DNA-based technologies and understanding of the biology of how in the clinic patient's genome might change. A second area that you're going to hear, I think, a lot in next 5 to 10 years is the transcriptomic component. And we have all looked at RNA by various methodology. However, we have always looked at mRNA, which is really 3% of the RNA in the cell. 90+% RNA does not make protein. So all the drugs we have targeting BCR-ABL or targeting AKT or whatever else are all protein targeting drug. However, 90% of the RNA are not making protein, and they were not considered important. However, now in last couple 3 years, it is beginning to be recognized that this RNA plays as important, if not more, role than the proteins. So we have looked at it in myeloma. There was a publication again by Dr. Samur showing that there is a signature driven by this RNA, long non-coding RNA, do not make protein, that predicts outcome very significantly. Even when you look at MRD negative patient, those who have the signature on the good side for this RNA, they have much better survival in the lower curve compared to those who do not. So obviously, this RNA play a very significant role. And we have done this very interesting screen using Cas13 based method and identified over 100 long non-coding RNA, 101, that are highly expressed in myeloma and functionally important. Their absence or presence impacts myeloma growth. And so these are our future 101 new targets to go after. And predominantly, most of them are also present in other cancer. We have looked at 6 other cancer. They are across the board in multiple cancers, so it may have a wide application. And I'll give one example of one of those molecule called MIR-1792. We are calling it RROL1. So how does this RNA work? This RNA, in this particular case, works by allowing 2 protein molecules to bind to each other. So we knew that MYC binds to this molecule WDR82, and MYC does what it does, malignant transformation, etc. However, this study showed that these 2 proteins can bind only if the RNA is present. If RNA is not present, it won't bind. So it is a very significant role. And if you interrupt this, if you inhibit that RNA, cells die. So coming not to showing all the other data, when we use this antisense against this RNA in multiple murine model, there are 3 different models here. One of the model is the tumor subcutaneous model. The other one is systemic model, and you can see that by infusing these molecules, the tumor is completely gone. And this is a patient sample model. We took patient myeloma cell, injected in the mice, and the blue line is bortezomib in the group of mice with the patient cell, and it kills well. And this RNA targeting molecule has very similar effect. And so you could see that if it is as good as bortezomib, there is a good future for this particular target. So we have 100 more to go after. More importantly, this is antisense. And in the new world where RNA medicine with COVID vaccine and beyond has become very easy reality, small molecules are still easier to apply. So we have this great collaboration where we can make a regular chemical that binds to RNA and blocks its action. So if you bind to RNA, that RNA will not do what it's supposed to do or will not let the proteins bind to each other. And so it's a small molecule like anything else. And one of the small molecule made is against MYC. And this paper was published earlier in Nature showing one of the first one where this molecule can lead to inhibition of MYC RNA. And you can see that when we give it to myeloma in the mice model, there's a significant reduction in the tumor volume, and also the disease in the mice goes down. So now stay tuned for a lot of small molecules that are now targeting RNA, not protein. So the final thing is therapeutics. So we are beginning to understand various parts of biology as a new areas, new frontier. Therapeutics have changed in these 30 years from VMCP, VBAP, to we are having 19 new drugs. I think it's covering the last 3 drugs, the last 3 bispecifics. And this has happened in 20 years. We have 1 new drug in myeloma every year for the last 20 years. And if we look at the projection, we'll have 15 more in next 7-8 years, 2 more per year. There are lots of promising one. I think that Dr. Jagannath described yesterday in his talk, and you will hear more about it tomorrow in Dr. Raj's talk. So great excitement for clinical purpose. And what has it done? Instead of what that patient 30 years ago was to get a hemibody radiation and go on hospice for maybe survival of 6 months or 6 weeks or less, now the PFS is over 6 years. In one of the newer study, it's expected to be over 12 years. There are 8 drugs in US which are approved as a 5th line treatment, and overall survival is definitely way beyond 10 years in most of the currently treated patient population. So great change in the field. And what is happening is that there are more and more patients who are surviving. There was a time when there were around 11,000 new cases of myeloma, and the prevalence used to be around 40,000 cases. Because patients survive much longer, more recently, this difference has become more than 150,000. This is US number. I think it probably applies everywhere else. And so there are a lot of patients who are surviving, who need treatment, who need better approaches. And the changes happened with the high-dose era, then there is an IMID and the PI era, then the second generation carfilzomib, pomalidomide, and selinexor, another drug came about, and now is the immune era. And this immune era is going to make the death rate and the new cases go really quite wide. And so we need to have a lot of other newer things available. And you have heard quite a bit about how quadruplets are changing it. And you can see just using quadruplets. ESA-KRD, one example, in one of the MIDAS study from French group, provides almost 60% MRD negative CR. So we get incredible responses even with these drugs, even before transplant is done. Again, that particular study is looking at whether transplant is needed or helpful in this patient population or not. And what these new drugs has done is changed the field, that our drugs, which are now listed here, are the old drugs from len, bortezomib, carfilzomib, pom, and isatuximab, and daratumumab, where the response rate for single agent is around 30%. We're in a very different world where responses are 60 to 90% with the newer immune effector cell therapy and bispecific antibodies. And so I think we have to keep in mind that this is where the field is moving. Instead of getting barely a minimum response, we used to have 30 years ago. One issue is though is, and which we are very envious of our colleagues in lymphoma, this is a post-CAR T cell curves for CD19 targeting CAR in lymphoma. And you can see that there is a clear cure fraction, around 40 to 50% post-CAR T cell. And if you look at the 2 of the newer studies that you will hear more about, KarMMa-3 and CARTITUDE-4, the curves are still going down. We don't have a yet plateau in the curve. And so there is a difference. We have still a hurdle to climb. And what is the challenge here? Why do we not get to the lymphoma world, or how do we get it? I think we are not yet killing myeloma cell adequately. Maybe it's because of the niche where the cells are hiding, where the tumor, where the CAR T cell scanner cannot reach, etc. Toxicity is another problem where we cannot give beyond certain level, certain dose. And then, of course, the problem with access. I mean, there is waiting list to get CAR T cells, and also the cost. So the multiple thing. And in that regards, again, there's a huge new research activity going on in our group, in other groups, to develop newer CAR-T products, newer bispecific products. For example, new targets. There are not many new targets on the cell surface anymore. So we have this new antibodies that acts like T-cell receptor. So they can target intracellular molecules using this, and a CAR developed using that kind of antibody can really kill the tumor cells specifically. Another example, this BET CAR, is where we make a CAR that does not target myeloma directly, but it targets a protein or a product. And if we give daratumumab, which is tagged to that product, then that product will bind to CAR, dara will bind to myeloma, it becomes a functional CAR. Tomorrow you can give an antibody tagged with the same product with ilotuzumab or the BCMA. You can change the target very easily and frequently. So you could say a modular CAR product. And there are many new developments happening. One of the development is where we can look at where does the CAR go and stay. So this is one of our colleagues at Dana-Farber has developed this CAR enhancer, and if it is tagged and injected, you can see where the CAR T cells are growing, CAR T cells are present, where they are eliminated from. So stay tuned for a lot of new advances in this area. Finally, I think there is going to be this total immunotherapy concept. You will hear a lot more about this tomorrow with Dr. Rajesh, sequencing-based thing where how you would combine CAR T cells with bispecific and also the immunomodulator with certain maintenance, etc. And what is this all going to lead to? Basically, improved response. And improved response, again, MRD has been the key word for a long time. We had, all of us combined, had this big project. It was run by the IMF, and you're going to hear a lot about IMF from Dr. Rajkumar in a minute. But working as a group and led by IMF, we did this I2 team project to get MRD accepted as a key endpoint for clinical study. And our efforts were successful because FDA accepted that. And this is the data that shows with 12,000 patients that MRD negativity provides superior progression-free survival in newly diagnosed and relapsed patient and improved overall survival in this patient population. So this is where we are all moving towards. The progress has been so much that, of course, MRD is being utilized now clinically. It's being utilized in drug approval. There's a first clinical study in US was recently approved for initiation with MRD as the primary endpoint for approval. But this has also led to now real benefit in patients being potentially cured. Dr. Jagannath mentioned that certain proportion of patients probably are getting cured because they haven't relapsed. So we had a meeting that Dr. Shaji Kumar led recently a month ago to redefine response in myeloma. And you will hear about it. We'll have publication soon. It was part of the, again, IMS, IMWG effort. But one of the key points that is interesting, which was discussed there, that now we need a definition of cure. When are we going to cure myeloma as being cured? So far, we didn't dare to even raise it. But in this meeting, we had some proposal, and in the final version of the manuscript, you will see what we end up with. But this is where one of the possibilities is that patients are MRD negative with 10 to minus 6 level, so as deep as you can go. Duration would be 5 years. They would be without treatment for 1 year, and MRD is sustained for all these 5 years. And so that's a starting definition for when we can tell patients that probably you are cured. But the great progress is from doing hemibody radiation, we are now talking about cure in myeloma. So I think I would stop there. This is the gentleman who has done a lot of genomic work with our group. He's the super bioinformatician. This is the rest of my group in the lab on the research side, and multiple collaborators all over. So I would stop there, and thank you very much.
Thank you. Thank you. Thank you, Dr. Munshi. That's a long journey. Growing from the streets of that is so. Thank you, Dr. Munshi. Such a long journey. Just to quote Rohinton mystery. But it's such a wonderful journey. It's a long journey, one-way ticket. So if you want to do well in your life, buy one-way ticket. Don't look back. And Nikhil, I know very closely for a long period of time. What the talk tells us that we need to go beyond our clinics. We need to know lots of basics. So you need to know molecular biology. I think you stay there. I mean, Velu says that everything is changing. Keynote address also changing. There should be some questions and answers. I think that's the way to go about.
Yeah.
So basic sciences, all of us, I think we need classes now. Young ones need classes now because there cannot be division between the basic science and the clinics. We need to understand everything, what is being told. Ritu and all do it for all of us here. And few questions and answers will be good.
Thank you, Dr. Tapan. You know, when we were students, we used to have these famous keynotes, but we were told in bold letters, no questions in keynote. So what was the key to that note? I never understood. So I think I said our first change is that they will be invited questions, if you don't mind, sir.
Oh, of course not.
Yeah,
of course
yeah.
not.
Actually, bench to the bedside and bedside to the bench. And that's made the whole difference. The clinician takes his problems to the lab and brings the lab back to the bedside. And that has been the change among clinicians with having their own labs, you know, the excitement. And in our country, I think we are catching up. We are definitely, you know, looking forward to doing many things that are happening in the world. And what a talk you've given. It's really been great listening to the developments and the journey. And I'm going to start by requesting our mentor and our teacher, Dr. Marman, to first ask the questions, and then we'll open it to the house. Dr. Marman, sir.
Nikhil, thank you for that fantastic talk. I have one question. You told us that hyperdiploidy of a particular chromosome, in your case, was seen at the age of 13. Now, this was in a random population, or was it in a myeloma patient where you look back on tracing? And that leads to the question that what proportion of people in the general population are likely to have a trisomy of a particular chromosome, which actually goes away and doesn't lead to disease. So I know that in the Guthrie cards, babies were found to have mutations in utero, which subsequently went on to develop leukemia. So can we make that same analogy? Will anybody who at the age of 13 has a trisomy go on to develop myeloma?
Yes, that's a super good question. So this study was patients who had myeloma, and the samples were collected when they had myeloma, and then we backtracked by sequencing and this analysis. Quite prevalent in my guess. There is no way to find because there's a single cell, and we would not find it. We have tried to think of how can we look for it in patients who have not had myeloma. It's more complicated. But to your very, very important question, it is likely that this hyperdiploidy would happen and the cells would die out, or cell would not grow, or it would not get the next hit or the next hit to eventually become something. And so I think this clock-like mutation is very interesting and kind of sounds scary, that we all have cells in our body, every cell, with 1,000 or more mutations. And they're random, they're all over, and they're not going anywhere. So the defense system, and that's where the earlier discussion about immune system comes into the picture, that these cells may be recognized, and at some point, before they go rogue, they're killed or suppressed. And so I think that's what most likely is the scenario. When we are exposed to something, chemicals, maybe this one cell has a little more predilection to be abnormal, and that's how they may develop. Or when immune system would go down, or cytokine milieu changes with inflammation or infection, maybe that's when these cells might have ability to raise the head and cause something. So I think that's a theory. We don't know the practically true.
The new definition that you showed on your last slide, very interesting. And the last line of the last slide was normal immune function. So normally we look at B cell function and immunoglobulin profile, and we actually think we've got the case covered. What about the T cells?
So I think both theoretically we would need, if we really apply, and that sentence might change in the final version of what we do, because in the current treatment bispecific CAR T, whether patient would recover the function, we don't know. The discussion point was, do we care if patient's myeloma is gone, immune system is suppressed, the patient is cured, does it matter? Practically maybe not, or theoretically maybe not. Practically he may have infection, this and that. And so for calling a cure, maybe requiring normal immune function is asking too much, maybe unnecessary.
But don't you think continued immune surveillance is a thing goal that you would like to have?
Absolutely.
Because that's how it all started.
So that's the whole thing, that if the immune function is normal, then the sustained MRD might be sustained as a cure. If not, then there may be doubt that would there be another myeloma come up, let's say.
Thank you.
So, Nikhil, you are targeting proteins, targeting RNAs, and perhaps also targeting DNAs.
Mm-hmm.
What are the pros and cons?
So I think protein is the easiest. We know the most about it, the function, the structure. Every protein structure now, by computer modeling, you can know it. So we know a lot, and we can find the drug. RNA is totally unknown at the moment. And it just literally in the last 2 to 5 years where we are beginning to know. We still can't do RNA structure very well. The programs don't exist. They will come out soon. And how to target is also very novel. The MYC RNA I showed is literally the first small molecule targeting an RNA. And MYC being the easiest and good for myeloma, it's good for us. But that's one of the first. But you will see a whole plethora very soon because now the concept is out. So RNA is next. Targeting DNA is complicated. DNA is permanent. And so to target DNA, are we going to cause more problem or less? We don't know that. One of the ways we have worked on that aspect is the genomic instability. I hesitated because one of the definition of true high risk would be a genome is unstable, and that's a bad myeloma. And so we have now actually drugs using certain targets in the stability pathway that can make the genome stable. So if you have DNA that does not change, acquire new mutation, then that myeloma can be killed easily and or may not become resistant, etc. So, but that is more complicated. We need to learn even more than what we do in RNA.
Dr. Mahaman has a question.
Nikhil, one more question. You told us some scary information that the number of mutations after melphalan increases significantly. And you left it there and said, yeah, I'm not going to say anything now. But the question to you is, does it mean that at some point in time, in fact, a transplant is deleterious? Because I asked Shaji this question yesterday. If you have quadruple therapy, do we have a randomized trial which compares quadruple plus transplant minus transplant? And has anybody shown a randomized trial difference?
Yeah.
So the question to you is a bit futuristic, that when will we drop transplant in the algorithm, saying that new mutations are coming and these may in fact give us a problem later?
So that's a very intuitive question, and I literally did leave it at where I left it for good reason, because it requires explanation, but it's a very good question. So when we had this data, it's clearly there are 6,000 more mutations, there is no question there. For an even higher end paper, we looked for what does that mean? Is 6,000 more mutation makes it a bad myeloma or not? And we have looked at every data set, and we have good friends and colleagues all across the globe with good sized data sets from French to Spanish to German to in US. And no study shows that post-transplant myeloma is a bad myeloma. Based on the data we have, none of the studies are perfect to answer that question, but we could not find a figure where I would say that post-transplant PFS is bad. And so why is that? So in this paper, we have figure that I didn't show one possibility is that more mutation leads to more neoantigen presentation. So in the paper we have a figure that post-transplant myeloma has significantly higher number of new antigens compared to non-transplanted. So maybe that myeloma is more immunogenic, and with all our immune-based treatment, they don't do so bad. So one can totally reverse it and say it's good to do myeloma, get more mutation, make it more immunogenic, and then maybe treat better. I don't know that either, but that's a counter argument. So I think at the moment, although this looks kind of ominous, it doesn't seem to be as bad, and we still need to understand why.
Rizwan, do we have to stop, or we can open the audience?
So we can open to the audience.
Okay. Hemant.
So Nikhil, truly wonderful talk. Thank you very much. Simple clinical question, like not high profile like the chairperson's question. You do a 4-drug or a 3-drug induction, you get the patient into CR. Why do we not move our most effective treatment, which is, I think, CAR-T or bispecifics right at that time? Not do the transplant, no maintenance, just do the immunotherapy and that's it.
So currently there are two, at least one good ongoing study, more than one, to do exactly that, randomizing between transplant and bispecific. Endpoint is MRD. My guess is CAR-T will come out ahead because it gets more MRD. And that is literally in works. In next 2-3 years, we will come out with a clear understanding that in post-induction, CAR-T would be the way to go, not necessarily transplant. Then mutation and other questions would also be less critical.
Any other questions? Yes.
Fantastic talk. Your work on lineage detection, where you show that even in 13-year-olds you're getting myeloma initiating mutations. Some of this work has been is a similar work originates from myelofibrosis group from Jyoti Nangle's group in Sanger, where they showed that initiating mutations can be detected in hematopoietic stem cell colonies, even at an in utero stage.
Correct.
But if you think logically, it's a bit absurd, to have something like this at an in utero stage. Perhaps the focus of this, rather than assuming a simplistic linear progression of cancer, is to focus on what drives these changes and how the immune system fails to control it or controls it to develop cancer. Your thoughts on this?
So what drives is what my answer to Tapan's question was, that there are processes identified. Most of them are in direct or indirect way connected with DNA repair pathways or genome maintenance pathways, a better word for it. There are many good targets, AP1, EXO1, TTK, PPK. These are all targets that if you inhibit them, those mutations may not happen. Again, this is a very double-edged sword, where you could target this to prevent, you might cause more damage because it's not repairing something. And so these are very complicated manipulation technologies. So good in the lab. It's probably some of them are safe enough for clinic, but not to go so early on to prevent it. And the point is that the immune system does kill most of them. That's why we might have 1,000 mutation, but all of us are quite okay. And so I think there is immune surveillance. When we lose it, the immune aging that we talked earlier might come into picture, and then we may lose it, etc. So I think your question is very appropriate, that should we not go after the surveillance mechanism rather than not? And I think that's partly what we are beginning to do, whether it is nutritional supplements or something else.
Last quick question by Dr. Mishra.
I think fantastic talk as usual. And whenever you speak, your fundamentals are so strong.
Thank you.
Every time I listen to you, I get depressed. Because I thought that we are catching up, but we are not catching up at the same speed that you are running. So I think whatever you have shown, we are way, way far behind. You mentioned about different techniques to be used, starting with genome-wide sequencing, microarray, and all those stuff. I think we in India, not many centers are geared to do that kind of work. infrastructural constraints, platform constraints, expertise constraints, everything is there in most centers. So if you sum up the translational aspect of your talk that you have just given, which are the ones that are going to figure in the IMWG guideline, that these are must doing, these are desirable, and these are in the realm of research? Because at the present moment, even though we consider ourselves to be lucky to have many of these platforms, we don't do NGS as of now in myeloma. We do a lot of FISH. We have a 8 of his panel, and we do flow, next generation flow MRD, we do all that. But I think listening to you, I am depressed.
I think first of all, I must say that I'm also from India. So I think we are all contributing in our way. You have a very important question, which of these technologies are for the clinical purpose, like day-to-day purpose, and I think you enumerated right ones. I think flow technology is available, accessible, affordable, I would think. The sequencing is becoming cheaper. It used to be $5,000 per sequence, now it's $200, and in India it's even less than that, etc. So it's actually cheaper than FISH in some settings in our case. So that will become reasonably acceptable methods. Mass spec is also not expensive in the right way. Not today, but very soon. So I think, but your point is well taken, that to help identify which technology we should have for good day-to-day clinical care and which technology are a little bit more for science and not for day-to-day use. So I think that's a good point.
Thank you, Nikhil.
Thank you very
and
much.
One more round of applause for a fantastic talk.
May I request the chairpersons to present a small souvenir to Dr. Nikhil Munshi, Professor Nikhil Munshi, please. Yeah.